Over the past decade, CMA and the Henry Schein Cares Foundation have been closely aligned in our efforts to improve access to quality healthcare and health equity for at-risk and vulnerable populations. This includes our work in partnership with the CMA, the Santa Fe Group, and a myriad of healthcare professional associations and other organizations to successfully expand Medicare coverage for medically necessary oral care. And our work in concert with clinicians, laboratories, and social service agencies to deliver free oral care to Holocaust survivors unable to afford the care they need through the Alpha Omega Henry Schein Cares Holocaust Survivors Oral Health Program, as well as our leadership in catalyzing public-private partnerships with professional associations, patient advocacy groups, dental and medical schools, policymakers, supplier partners, and our customers to advocate for and help improve access to culturally competent oral health care for individuals with disabilities. We are so pleased to support CMA's 10th anniversary summit and celebrate the incredible contributions of the Center for Medicare Advocacy and its many incredible partners.
The kind of food we had during these years, like all those people, was horrendous. I mean, it was the minimum just to survive, basically, but it created lots of problems for people because I knew that if nothing would be done, I would lose some of those teeth. When the social worker told me about this possibility, it was a new possibility, I was very happy, really very happy that will happen for me, for other people like me.
And now, the Henry Schein Cares Foundation is delighted to welcome everyone to the Center for Medicare Advocacy's 10th annual National Voices of Medicare Summit and Senator Jay Rockefeller Lecture.
So I'm Judy Fader. I'm the president of the CMA board and delighted to add my welcome to all of you on behalf of the Center for Medicare Advocacy. Medicare is almost always in the news. And I would say budget season puts it in the news. And I imagine that many of you, like me, watched the State of the Union address. I'm not hearing any laughing yet, but I'm looking to evoke some pleasure. And I would like to say just to share how much I enjoyed watching President Biden spar with the Medicare opponents and say they would never touch Medicare. Well, they're going to need to be held to that, right? And I do wish that, along with Social Security, Medicaid had been added to the list, and now it's clearly in the crossfires, as are other programs. But even without being a target in the federal budget battles, Medicare always needs our attention. Even with allies in important policy positions in the administration and the work of those on the Hill, they need people like the people in this room and the Center for Medicare Advocacy to keep an eye on them and to keep pushing them to keep Medicare as strong as it needs to be. And it's why I am so proud to be the president of the CMA board, because they do pack a powerful punch. And as Judy said, the small but mighty band is ever mindful of what's going on in the Medicare program and attentive to persuading and pressing those who run the program and those who would undermine the program of what needs to be done. But they could not do the amazing things I think they do without all of you. And it is a great pleasure to be in person this year, although I know we have some people with us virtually, so welcome to you as well. But it's really nice to be in the room with all of you once again. We must meet more often. So with no further ado, I know we're going to afternoon, both stimulating and uplifting. And I'm going to turn it over to Judy Stein, who leads the Small But Mighty team and is, if I may say, small but mighty in her own person. I'm going to turn the podium over to you.
We Judys try and pack a punch, right? Well, welcome. And yes, we have over 1,000 people joining us today virtually. And I want to say, let's everyone welcome them. From 50 states, South Dakota brought in the 50th state. And we're grateful to them. The possibility of both being in person and being so accessible and allowing those who couldn't come here to DC for one reason or another to still be part of this day and this mission that I intend to bring up today and have us go out energized to work together to make sure that we have a really active crew going to be pushing for social and healthcare justice for all. And that's why we're here today. And we welcome everyone remotely. And of course, it's so lovely to see dear friends in person. This afternoon is brought to you by a number of people. We are not charging for this event in order to be inclusive. And that is made possible by the Arnold Venture sponsorship, which will also is allowing us today to have closed captioning and inclusivity in that regard, as we try and have all people welcome to our activities. We also have the broadcast with our wonderful Spark Street partners, brought to us today from the Henry Schein Foundation sponsorship, which you just saw their wonderful video, and they are part of our effort to enhance the availability of oral health care under the Medicare program. We are also persistent. We've been talking about a lot of the battles that we'll be talking about today for many, many years, but we're going to win. Little by little, we are going to win these incremental improvements. Finally, we have a really dear relationship with the Christopher and Dana Reeve Foundation, which has early on shown support and confidence in the work at the Center for Medicare Advocacy, including hosting, sponsoring some webinars that our Associate Director, Kathy Holt, has run, including with me and with others on our team. And I am really delighted to welcome our first speaker from the Christopher and Dana Reeve Foundation, Regina Bly. Regina is a remarkable advocate, and the Christopher and Dana Reeve Foundation are the sponsors for this venue. We are able to be here today because the Christopher and Dana Reeve Foundation has sponsored us and allowed that to happen. So this is our first opportunity to convene in person since 2019, when on May 10th, Matt Shepard and I and a few others were saying, okay, we got to get going because we're going to be meeting at the Kaiser Family Foundation on May 30th. And then one of our colleagues said, well, I hear there's some things closing. And we said, well, maybe call Tricia and Lorraine and see what's doing. And they said, no, like we're closed. And I said, and Tricia said, but we're opening on April 1st. And I said, what if you open on May 30th? Well, anyway, plan A, B became plan A. And we were really cutting edge doing our first remote summit. I was thinking we would send everybody popcorn so you would come, but even without the popcorn, people came. So this is our first opportunity to be in person since then in 2019, when the pandemic reminded us all how much health, science, quality healthcare, and relationships matter. This year, about 100 of us are gathered together in person. What beautiful faces. It's really a delight. And over 1,000 have registered from all 50 states to join us remotely, and we welcome you again too. In person or remote, thank you for taking part in this effort to build a responsive health system and a Medicare program that attends to the needs of all its beneficiaries. Together with all our varied skills and experiences, we can improve the future of Medicare and access to quality health care for all human beings. And I emphasize all. So let's get started. First, we're going to hear from my dear old friend, Regina Blythe, from the Christopher and Dana Reeve Foundation. Regina?
Thank you so much. Hi, it is truly an honor to be in the room today. I can't tell you how excited I am because of the topic that everyone is going to be discussing today. But first, I wanted to give you some information about our organization, just in case you didn't know, so that you can maybe partner with us in the future and maybe collaborate like we've been doing with CMA. On the screen, for those who are not able to see, it is our opening slide that has the Christopher and Dana Reeve Foundation. It has my name, Regina Blythe, Chief Program Policy Officer. I oversee the National Paralysis Resource Center, and it has the name of the event and the date. So going to the next slide, real quickly, I'd like to talk about our mission. It has the words, our mission. It has pictures of people with paralysis being active and living a healthy life. And then it also has our mission, which it says we are dedicated to curing spinal cord injury by advancing innovative research and improving the quality of life for individuals and families impacted by paralysis. So in short, we have a shortened mission that is called Today's Care and Tomorrow's Cure. So today we're not going to talk about research, but we will talk about the care side. So going to the next slide, it has a list of programs that I oversee. We have a small team located all over the country. We're headquartered in New Jersey, and I have a small team of staff here. Kim Beer, who is our Senior Director for our advocacy and policy work. We're in DC. And so we have a host of programs that are beneficial for people with paralysis, and it goes beyond spinal cord injury. It's any form of paralysis, including traumatic brain injury. One of the things that I like to promote is our information specialists. They receive all kinds of calls from people across the country, from people who are newly diagnosed with paralysis or injured with paralysis, and they hear all kinds of terrible, horrible things, including you hear about mass shootings, but you don't hear about those who survive and now have paralysis. We take those calls and give them the resources and the help that they need, moving them in the right direction. We also have funding that is available for nonprofits who work in the paralysis space. We can't do it all ourselves, so we use them as an extended arm to be able to help people with paralysis to be able to be active and healthy and live in their life, such as myself. So going to the next slide, I really want to talk about this one because it shows just a brief snapshot of the history that I have, or not me, but the foundation has with the Center for Medicare and Advocacy. And that is, as Judy mentioned, our partnership when it comes to the webinars. And so we've had a partnership now since July 1 of 2018. And so we've had people register all over the country, and that's 5,100 people who have registered to attend our virtual partnership events. And actual people that showed up were 3,200 people. So they are smarter, well-informed because of our partnership. And we focused on Medicare and then also living with paralysis, how to merge those two together so that you are an informed individual that can live an independent life. We also have partnered together, and all of this predates me. I've only been with the foundation for a year, so I'm excited to extend these opportunities to continue our great work together. But we've also served on many boards and commissions together, advocating for Medicare, also paralysis, and then we've also have our information specialists, which I mentioned. We work with them on our critically hard cases around all kinds of things to navigating the insurance spectrum, from also just making sure that they're protected, because there are some things that have happened that require some legal assistance. And so the great partnership has been able to help people in the community be successful in that area. And they've also received some of our quality of life grants as well. So very short snapshot. I don't have the time to give you all of that information, but if you want to know more, you can talk to me afterwards and I can give you more details. So the next one is this one. So we were invited to speak as well to talk about our non-traditional partnerships. So this is our time where we get to focus on groups that don't necessarily focus on paralysis of any sort or disabilities in general. So we started out with the first event, and that's us working with Washington Post Live. We sponsored an event on the caregiver crisis, and it was an important one for us because, as you know, caregiving, it's a mess, but it's there. And so we in this room are going to make sure that it gets better and better every day. And so we were promoting this out to people all across the country, even across the world, so that they can know more about the caregiver crisis and what they can do to play a part. And then also recently I was in Austin, Texas, and I was able to speak at a little trendy, cool conference where at least 100,000 people attend. I'm telling you, really cool and swanky. There are young kids all over the place. But it was so cool that they were in the room to learn about these small nonprofits doing great work with only 2 cents. And we were giving them the information about, instead of going to these big box organizations, support us, because we're doing good and we need your dollars as well to be able to do the work. So we had the opportunity to talk to the young folks about what we do and why it's important to support small nonprofits. And then I also was at a group for AIMME. It is a whole group of people who are associated with marketing and advertising. And so I had the opportunity to talk about why it's important for people with disabilities to be represented in an authentic way when it comes to marketing and advertising. And so I thought that was really important because we all should be represented, and when we do it, it should be in the most authentic way. And so we looked at ways to make sure that the media is representing us in the way that shows that you really respect receiving our dollars. And so the next one is just an example of our exhibit booth. We exhibit at organizations all over the country. We just got back from Atlanta attending a research event last night, and it was really wonderful. And the last one that I would like to highlight is our partnership with Peloton. And this gives us an opportunity to work with Peloton to extend their footprint when it comes to having adaptive, accessible, inclusive training classes for people and also for caregivers. So we had a special opportunity for caregivers to also be integrated in a part of the Peloton experience. These are all activities where initially disability wasn't the main topic, but we made it the main topic. We're going where you're at and telling you why disability is cool, why it should be followed, and why you need to be a part of the process. So this is kind of the Reeve landscape, and hope that you can join us in our effort to make sure that people with disabilities are living the best that they can. So the last slide is just me saying thank you. And again, why I am so excited to be here, because it's focusing on caregiving. And as someone who is a 36-year gun violence survivor, I can tell you, watching the news, reading the news, every day there's some sort of gun incidents going on, and there's like trauma all over and over again. And when I was 10, I was shot in the neck with a rifle at a slumber party. Pre-ADA, I was a small town girl of color, and we had no means. But let me tell you, there's a saying that we had that I heard growing up, saying hood rich. And I don't know if you've heard that. And that's where you have all kinds of things to make you look like you're fancy, from your car to big screen TVs, but you're living in low income housing. And so I took that term to say, growing up, I was services rich. We had no money, but we had access to Medicaid and the things for me to be able to thrive. And so when I was in Atlanta, some stranger came up to me and said, thank you for what you're doing. Keep up the good work. And I'm like, you don't know me. Like, why are you saying that? So then I kind of like, is it because of the wheelchair? Like, okay, I guess. But really, it's because of my mother and my father who took care of me when I was 10, didn't know how to take care of a girl with paralysis and couldn't feed herself at the time. That was my caregiver experience, and it continues today. And it was possible because we had services. Now, I'm not services rich. They think I make enough money to afford to do this on my own. It's not true. As much as I travel, I cannot pay for people to travel with me and provide the care that I need. So I have my partner who's done this now for the last 16 years. This shouldn't be their responsibility, and they're doing it without pay. They're doing it because they love us. I'm getting teared up. It just shouldn't happen. So this is why it's important for you to be here. Why am I teared up? So sorry. Because it matters, and because you are all brilliant. And all of you are one decision, one vote away from making sure that caregiving is equitable across the board. Thank you. Passion up here. So sorry.
Yeah. You can see why we had to have Regina with us, and she speaks to the entire mission for so many of us. Those who don't need care today may need care tomorrow. Those who are given care today may need care tomorrow. And I also neglected to tell you that Regina is the Chief Program and Policy Officer at the Christopher and Dana Reeve Foundation. I want to thank you with this book from John Lewis, March. And we will continue to make a way where there is no way. And we will continue to tear up because it's the power of the moment. Thank you for being my friend. Thank you.
Thank you.
And now we are going to hear from our dear friend, Tricia Newman, who is the Senior Vice President of KFF and Director of KFF's Program on Medicare Policy. Dr. Newman's work at the KFF Not Foundation, they've changed their name to KFF, focuses on a broad range of issues pertaining to Medicare program and the population it serves. And we advocates could not do our work without the work, the data, the information that we receive from Kaiser. We're really always grateful for KFF. And personally and from the organization, thank you for being our dear friend and for always willing to help us learn. So, Tricia Newman.
Thank you, Judy, and thank you, Judy. I was kind of going on that small and mighty theme that you both are, embody, but then when I heard about trendy and cool, I thought, well, maybe that's what we all need to be too, as we sort of are. That was just so moving. And I think what we heard from Regina is the importance of public programs, right, like Medicaid in particular, in that particular case, and family, and somehow how people do their best to piece it together and to thrive in our whatever capacity we can. And I'm going to talk a little bit more about what Medicare could do more of, because I think what we have learned is that Medicare, as you'll see, is a very popular program, but it has some shortcomings that really come out when you look at the experiences of people with disabilities. So if I could have the first slide, please. Here you see what I just said. Medicare is a very popular program. It ranks right with Social Security. Actually, Medicaid is not far behind. It enjoys broad, favorable support among the public, and that's pretty good. And I think people in this room would like to keep it that way, and I know you're working very hard to do that. At the same time, and I'm not showing you all the numbers, people in the public say there's more work to be done, and they are anxious that Medicare will not be there for them when they get older, which is a serious concern and one that needs to be addressed. So that comes mostly from people who are in the 50 to 64-year-old range, who are kind of worried because they know just how important Medicare is, and they can't wait to get there. And if you talk to people you know and focus groups, people say, I just want to get on Medicare, because they have a sense of that will make them secure. Can I have the next slide? Back by popular demand, because Judy and David always ask for this slide, I want to set the table a bit just by saying who it is that Medicare covers. And as you can see here, we know that Medicare has many people, some in this room, who are healthy, who have enough resources, but 1 in 4 people on Medicare have a functional impairment. 1 in 5 people on Medicare report being in fair or poor health. About 1 in 5 people have a cognitive impairment, and so on and so forth. You can see here that about 13% of people on Medicare are under 65 and qualify for Medicare because of their work history and because of a permanent disability, and they get Social Security disability. Often this group doesn't get enough attention when policymakers talk about it, right? Policymakers talk about seniors on Medicare. And honestly, I slip sometimes and I talk about seniors because it's sort of shorthand. But there are millions of people on Medicare who are under 65 for whom the program needs to work as well. And they look a bit different than the elderly or the overall population. So while I just said 1 in 4 people on Medicare has a functional impairment, that's about half of people who are under 65. And about more than half of people under 65 on Medicare have a report being in fair or poor health, and nearly half report having a cognitive impairment. So when we talk about making Medicare work for everyone, I think this is a population that clearly needs more attention. And now one of my favorites, the next slide, talks about sort of the economic resources of older people. And this too, I think, does not get enough attention because you sort of have an image of people who are golfing and enjoying their retirement. But the truth is, half of all people on Medicare live on an income of about $30,000 or less. 1 in 4 people on Medicare lives on an income of about $17,000 or less. So a lot of people say, yeah, but think about the savings, and they can use their savings in order to pay for long-term care. But here again, you have half of all people with savings of about $75,000 or less, and 1 in 4 people have savings of $8,500 or less. And I could do the same thing if I talked about home equity. The other thing that this chart shows you is the tremendous disparity in income and assets by race ethnicity. So if we just look at savings, while overall the median income for white people on Medicare is about $118,000 or less, that number drops to about $15,000 for Black beneficiaries and to about $10,000 for Hispanic beneficiaries. So the capacity to pay for services that are not covered by Medicare is very unevenly experienced by people depending on their circumstances, and it looks very different for Black and Hispanic people on average than it looks for white people. Can I have the next slide? I'm focusing a bit on the under 65 disabled population on Medicare because we're interested in that today, and I think it needs more emphasis. So overall, people on Medicare enjoy good access to care. They report being happy, not waiting too long to get to see a doctor, not going without care due to cost so much. But there are real differences between older and younger people on Medicare, and I'm just going to cite a couple of numbers. So overall, less than 10% have trouble accessing care, said they had trouble accessing care in the past year. Okay, that's good, less than 10%. And I actually think this chart makes it look worse than it is overall for the Medicare population because the line seems so long. But the rate is double that for the under 65 population. Overall, less than 10% said they delayed care due to costs. Again, it's more than double that for people on Medicare who are under age 65. This says to me that more work needs to be done to figure out why it is people who are under 65 are experiencing more problems accessing services and paying for care that they so need. So while the program is working relatively well for the bulk of the population, even people who are older than Medicare experience gaps and challenges. Could I have the next slide, please? This past year, Congress did a remarkable thing in passing the Inflation Reduction Act, which provides significant benefits to people on Medicare, particularly people with Part D coverage. We did a lot of work on the out-of-pocket cap and how much people were paying for their prescription drugs. The fact that out-of-pocket spending is going to be capped at $2,000 in 2 years and will be capped next year is fabulous for people who are really sick and take very expensive drugs. My sister, for example, was paying more than $10,000 a year for her drug for ovarian cancer. Who can afford that, right? So this is really, I think, one of those remarkable things that is not getting a whole lot of attention, and our polls say that people don't really know about it, so spread the word. But as you all know, there are a lot of things that are not covered, and so that's where people do have cost burdens. We've already heard about dental care, which didn't make it through a couple of years ago when there was attention to that. There's no out-of-pocket cap for A and B services in traditional Medicare. There's limited premium and cost-sharing assistance for low-income people, and it's subject to an asset test, which is not the case for some other programs, and long-term services and supports and caregiver supports and that whole continuum that everybody just kind of throws their hands up and says it's too expensive, we can't deal, except for maybe Judy, who keeps coming at it with good ideas, and we can't give up because families really can't afford the devastating illnesses, the devastating costs associated with long-term services. So it's no surprise, and you look at the next slide, that people have relatively high out-of-pocket costs, and they're higher for people in relatively poor health than they are for people in better health. And this is just for people in traditional Medicare, because we don't yet have good data for people in Medicare Advantage, which is my transition for talking about Medicare Advantage, because I think it's important that we all understand just how much the Medicare program is changing, kind of in plain sight, but without a lot of policy debate. If we had been here 10 years ago, we might have been talking about what's going to happen as a result of the changes made by the ACA, and will Medicare Advantage stay or go or grow? As some of you remember, when the ACA was being debated, there was all this concern that plans would pull out, enrollment would plummet, benefits would be cut. And that's why it shouldn't have happened. All the payment reductions that were in the ACA that did happen, as you can see from the next two slides. Go one more slide, and then one more slide. Thank you. This shows you enrollment growth of Medicare Advantage. So any moment now, we're going to find ourselves with more than half of all people in a Medicare Advantage plan. I don't think when people were talking about Medicare for all, the progressives were thinking this would be United Healthcare and Humana for all, but really that is what Medicare is beginning to look like. There are projections that enrollment will grow to 61% within a decade. I, for one, think that is a conservative projection. All the ads you see on TV, all the goodies that are drawing people to Medicare Advantage, I wouldn't be surprised if enrollment grows substantially faster. And in terms of why people are growing, can I have the next slide, please? Why people are moving, gravitating to Medicare Advantage? It's kind of irresistible. I mean, look at these extra benefits. Here is vision, hearing, vision and dental, fitness and dental. 96% of enrollees, or more than 90%, are offered all these benefits. Can I have the next one, please? And then there's over-the-counter meal benefits, transportation. I have a colleague whose mother begged her to come over and go shopping for over-the-counter meds because she had a free card from her Medicare Advantage plan. My friend didn't really need anything, but she got stuff anyway. And then if you look at the next group, thank you, here are services that are really needed by people who are frail or people with disabilities. And you can see that many people are not offered these services: in-home support, bathroom safety. And that's something that I think that matters a lot, because those benefits are what are very important to people. And I think long-term care advocates have been hopeful that Medicare Advantage could be the answer for, or at least part of the answer in providing all these services, but that has not materialized yet. The other thing I want to point out about what we know about these extra benefits, we know that they are being offered by plans. We don't know what people are using. So we have no idea the extent to which the money that is counting toward extra benefits is actually being spent. Can I have the next slide, please? One of the reasons why Medicare Advantage plans are able to offer these benefits is because of the payment formula that currently allows Medicare Advantage plans to be paid more than payments for traditional Medicare for people who look very similar. So here you see that Medicare Advantage payments are on average 106% or 6% higher than what they are under traditional Medicare for similar people. So this is a system that is not designed to save money as it was initially. It was initially Medicare was paying 95% on the dollar because Medicare was thinking that plans could save money. Plans do save money on providing Part A and B services, but the payment system is not designed to capture the savings back to Medicare. Can I have the next slide? So why are plans in so interested? And we know that they are. Every year more plans are coming in and testing it. This is our analysis of gross margins that we do at least once a year. I think we're about to update it, but we compared gross margins for the group market, individual market, and Medicare Advantage. And this is not quite the same as profit because it doesn't take into account certain things, administrative expenses and taxes, but you get a sense of the relative money, the money coming into Medicare Advantage relative to other health insurance markets. So it's no surprise that the big insurers want to play a major role here, and smaller insurers are coming in. And the bigger, one of the insurers, Humana's, just announced it really wants to focus on government programs and get out of other markets, and this sort of gives you a sense of why. But there are trade-offs for people who sign up, and those trade-offs are not always transparent. So if I could have the next slide, please. We've started to look at prior authorization for different services, and what you can see here is that virtually all enrollees are in plans that impose prior authorization requirements for high-cost services, like Part B drugs people would take for cancer, skilled nursing facility, inpatient stays, physical therapy, etc. So we have this information, and then if I could have the next slide. We also looked at denials among the 35 million prior authorization requests, and what we saw is that 2 of the 35 million prior authorization requests were denied. So that's not a huge rate, 6%. But what's interesting is of the 2 million prior authorization requests that were denied, a small share were appealed, and we have some dispute among the staff at KFF about why, but I think it's because people have no idea how to appeal a request, and they think they just are overwhelmed by the process, and they don't know Judy Stein. But also of interest, those that were appealed typically get overturned. And so we have a system that maybe is leaving people with denied services where they're not taking action, and we have no idea what the consequences are. And by the way, we're about to put out a piece because we are struck by the lack of information we have on so many data fronts. And one example is this: we don't know denials by service. Seems like a basic thing. Plans obviously have this information, but it's not collected and not reported. For beneficiaries, there are plenty of trade-offs. If I could have the next slide, please. In terms of whether to be in traditional Medicare or Medicare Advantage. If for traditional Medicare, the reason to be in Medicare Advantage, when I'm talking to people, is it's simpler. It's one-stop shopping. You don't need a Medigap. You don't need a Part D plan. Lower premiums than Medigap. There's an out-of-pocket limit. You get all these extra benefits offered to you if you can use them. And there's a potential for care coordination that may not happen in traditional Medicare, but there are disadvantages as well. And our view is that people who are signing up tend to make these decisions in their late 60s and maybe early 70s when they're relatively healthy. So they're maybe not thinking about limited provider networks, which, by the way, are really hard to analyze and compare. The potential for higher out-of-pocket costs for certain services, more utilization review, and the problem that I hope somebody fixes sometime, which is there's a limited ability to switch back to traditional Medicare because Medigap doesn't have guarantee issue protection. So some people feel they cannot switch back because they can't buy Medigap policy. And that was something that I guarantee you was not thought about when the Medigap consumer protection standards were put into place. Moving forward and kind of circling back to what Judy was talking about in the beginning, Medicare's not quite in the mix. Can I have the next slide, please? Medicare's maybe not quite in the mix and discussions about the budget and the deficit, although I'm not quite sure. There was that fun stuff that happened at the State of the Union, and the latest proposal that came out of the House does not have Medicare changes, but we're early in the process, and there could be we don't know whether there will be a clean debt limit. We don't know whether there will be another process that goes with it that could involve bringing Medicare and Social Security into the mix. I've heard talk about a panel that could be convened. So who knows, that would look at sustainability. But whatever, at some point, Congress will need to step up to do something about the Medicare HI Trust Fund. You know, this number, this year of insolvency is not necessarily a fixed number. It changes every year. The current projections are 2031 until depletion. That could change depending on the economy or healthcare costs. That means there have to be some decisions that will be tough decisions about revenues and spending. And these decisions need to reflect the priorities of the public. And I hope you all will engage in that whenever that time comes. So you all have a lot of work to do, and I'm excited to be here to share in that. If I could just have the last slide, it sort of sets up a lot of issues for discussion. How are we going to finance care for an aging population? How are we going to improve affordability? How to set fair payments to healthcare providers and plans. That's huge. It may not be something that this group focuses on, but it's super important. And then lastly, but most importantly, probably meeting the needs of the most disadvantaged among us. And I know I can't think of a better group to be working on that. So thanks so much.
And a book for you. Oh, thank you. Did I give you March with the book?
I love it.
Thank you so much.
Thank you.
Thank you, Tricia. She is the champion of helping us know what's happening so we can use that information to fight for justice, for healthcare expansion, and for the Medicare program. For goodness sakes, Medicare Advantage plans must be required to give data to the public, right? What are they covering? What are they not covering? By service. The information we know from traditional Medicare, we don't have for Medicare Advantage. What appeals are being asked for? What appeals are being, I can't help but say, denied and denied again? In what care settings? So thank you for helping us fight that fight too. And now I want to introduce David Lipschitz, our senior policy attorney and associate director in our Washington, D.C. quasi office, and our panel on breaking down barriers to care.
Thank you, Judy. Thank you to all of you here in person and joining online. Before we start the panel, I'm just going to say a couple of housekeeping issues with respect to submitting questions for those of you online. If you are online, please submit questions throughout the event today. Beneath the webcast, I got to take off my glasses to read this, but beneath the webcast player, you'll see the Q&A tool. Enter your name and question and hit submit. We'll be monitoring questions as they come through and folding them into the conversations throughout the sessions as time allows. Okay, let's get started. Anyone who interacts with our healthcare system knows that there are myriad barriers to care. hurdles in between you and the care that you need. These barriers range from finding the right providers to finding the right treatment for you and having such treatment covered or authorized, to finding a caregiver and affording a caregiver, about which we'll be talking a lot more at the end of the day today. Oftentimes, these barriers have a disproportionate impact on people who need care the most. The Medicare program has rules, laws, regulations, guidance that spell out what beneficiaries are entitled to, obligations of contracting providers, and plans. These words often articulate what should be covered and what should happen. For example, in certain care settings, everyone should get an individualized assessment. There's no duration of limitation for the home health benefit as long as you qualify. And Medicare Advantage plans are supposed to cover everything covered under Parts A and B of Medicare. But if these words are not known, if they are not enforced, if they are ignored or misinterpreted, these rules and words merely become aspirational. Sometimes it is not the rules themselves, but rather the lack of following the rules that can create barriers of care for people. Other times, the rules are faulty themselves and need to be revised, and new rules need to be written. In this panel, we are going to touch on a few, but certainly not all, of barriers to care in the Medicare program and a few ways that we and others have tried to tackle them. This will include some of the barriers faced by individuals with chronic and disabling conditions, and a discussion of the Jimmo versus Sebelius lawsuit. It will also include a discussion of something that was just touched upon in the previous session, Medicare Advantage, and the challenges that the Medicare Advantage program poses, both at the programmatic and the individual level. Today, we have on our panel, in person with us, Rachel Madley and our own Wei Wei Kwok. We also have pre-recorded remarks from John Marmaru and Adi Barkan. And everyone's full bio is in the program for the summit, but briefly, Rachel Madley. Rachel, thank you so much for coming today. I know Congress is back in session, and so it's a busy time. Rachel Madley, PhD, is Health Policy Advisor for Congresswoman Pramila Jayapal. She leads the Congresswoman's work on all healthcare issues, including Medicare for All, Medicare reform, and healthcare access. Before that, Rachel was a Congressional Affairs Specialist for the FDA. Wei Wei Kwok is a senior attorney at the Center for Medicare Advocacy. She provides legal assistance, analysis, and education on behalf of Medicare beneficiaries in a range of areas, and she's also a good friend. Before joining the center in 2002, her experience included AARP Foundation's National Training Project and the Legal Aid Society of Hawaii, and I'm sure people ask you all the time, what led you to leave that job? For remarks that are pre-recorded, and we will hear, we have John Marmaru, who is the founder and executive director of 810 MS Specialty Center. He has a Master's of Science and doctorate in physical therapy and has had a broad range of experience in the rehabilitation field. John is joining us online, so hopefully he will be able to watch himself in his pre-recorded remarks. Adi Barkan is an organizer and campaigner and is founder and co-executive director of Be a Hero. Long an activist and attorney, since 2007, Adi's work has focused on healthcare, marshaling his own paralysis from ALS to urge Americans to demand more of our government. Adi's story is told in the 2021 documentary, Not Going Quietly, which I highly recommend to everyone to check it out. I forget which streaming service it's on, but it is on one of them at the moment. So Wei Wei is going to kick us off today by talking about the so-called improvement standard, which has been a significant barrier to care for individuals with long-term conditions, and what we tried to do about it via the Jimmo versus Sebelius lawsuit and settlement, now 10 years old. Wei.
Thank you, David. So it's an honor to be presenting on this topic with you and Rachel and John and Adi. I am just so thankful for and inspired by what the four of you do to fight for access, equity, and justice in healthcare. So yes, I have the privilege of talking about the Jimmo settlement on its 10th anniversary. At its heart, the case was about removing a barrier to care. Jimmo versus Sebelius was a nationwide class action brought in 2011 to challenge an unwritten policy that was being systematically applied to deny claims for skilled care in nursing facilities, home health, and outpatient therapy settings. And we have referred to this policy as the improvement standard. The case came about because we had been hearing widespread reports for some time that Medicare patients were being denied or cut off of skilled therapy and nursing, even though their health providers felt very strongly that they needed these services to treat and to maintain their health and functional abilities. But Medicare's contractors and also Medicare Advantage plans were denying payment based on this conclusion that they weren't expected to make significant improvement. And over time, because of these denials, providers were becoming very reluctant to serve patients with chronic, long-term, and progressive conditions that might not improve quickly, markedly, or maybe at all. And we knew that these denials were in violation of Medicare law, which provides very clearly that there's coverage, not just for improvement, but for skilled services to maintain a patient's condition or to prevent or slow further decline. And we tried, as much as we tried to show CMS that this, illegal rule of thumb was being applied in case after case, the agency just staunchly denied the existence of an improvement standard. So at that point, the center, along with co-counsel from Vermont Legal Aid and the law firm of Wilson and Cincini, sought injunctive relief in federal court on behalf of Glenda Jimmo and 4 other individuals, as well as 6 organizations, including United Cerebral Palsy, the National MS Society, and Paralyzed Veterans of America. So the case eventually settled with the agency agreeing to revise its guidance and to conduct an educational campaign to clarify that coverage cannot hinge on a person's ability to improve, but must be based on an individualized assessment of the person's need for skilled care. And more than that, CMS had to reinforce that that coverage is equally available for maintenance care and not just restorative care. So despite this important victory and the hope that it provided for many people, or provides for many people, I should say, we do still hear sometimes about decisions that deny payment or prior authorization solely because somebody has a chronic condition that is not expected to improve significantly. And this concerns us deeply and reminds us that our work to vigilantly monitor and enforce GMO will need to continue.
Thank you, Wei. So with that setup and explanation, before getting to the ongoing challenges of implementing GMO, we wanted to highlight how GMO is supposed to work in practice and highlight lift up the voice of a provider with whom we work, who has used GMO to the benefit of his patients. John Marmaru, in his recorded remarks, which you're just about to hear, will talk about his experiences as a provider of care to individuals with chronic conditions, particularly MS, and how GMO has helped both him and his patients. If we could please play John's remarks.
Hello, my name is John Marmaru, and I'm speaking with you today from Providence, Rhode Island. My role as Executive Director is both challenging and rewarding. I'm not able to be there with you today because my role as dad requires me to stay close to home. I'm very excited to celebrate and acknowledge the 10-year anniversary of the GMO settlement. This clarification happened in 2013. So much has happened since then. Progress in terms of maintenance therapy continues to move forward. This milestone would not be possible without the work and dedication of those at the Center for Medicare Advocacy. In 2008, I shifted my career to focus on those with chronic illness. The challenges that I saw, what needed to be addressed, was how do we as clinicians safely and effectively maintain gains for our patients after skilled intervention is stopped? In my view, the acute care system was doing what it was designed to do. It was doing a good job of stabilizing people from a medical point of view and getting them home safely. But once this occurred, care stopped for those vulnerable populations. There was nowhere for these people to go safely to remain stable and stay in the community. This was a big problem to me. Patients with chronic illness were often receiving care only when they became very ill. This type of episodic care did not make sense to me, and ultimately I viewed it as wasteful and it discouraged the patient. This was when I decided to start treating patients regardless of insurance restrictions. This was very satisfying, but it was difficult. Then the Jimmo ruling happened, and we were very happy. Of course, one reason we were happy is possibly we would be reimbursed for these very necessary services we've been providing for many years. But more importantly, I was happy because the spirit and the substance of the Jimmo ruling directly aligned with our mission. And it made sense. It's what was best for the patient. This is very encouraging to me. Jimmo was a huge victory for so many, and it's changed many lives. Patients with certain conditions cannot safely and effectively maintain gains, period. If Jimmo is not followed, many could have a negative event that will result in a hospitalization. This is a predictable pattern that I've seen for many years. It's upsetting to me because I know it doesn't have to happen. We have to find a way to improve this. The Jimmo ruling is an amazing achievement that would not be possible without the work of the Center for Medicare Advocacy. To my friends and colleagues, for the sake of our patients, we have to keep our eye on the ball. Rather than tell you how Jimmo has changed lives, I thought it would be better if I showed you. Enjoy and happy anniversary, Jimmo.
I've been to other physical therapy offices before, and I'd really noticed I'd do my 10 or 20 appointments, and then I'd have to wait 6 months to get more appointments, and I would really notice that I would get worse during that time. Whereas when we're coming here consistently, it's much better at maintaining progress. MS is such a unpredictable disease that, you know, you can't really compare yourself to where you'd be without it. But I know for sure that I wouldn't be able to still do some things I can do. I use a wheelchair full time, but I can still mostly be independent.
I've been to a lot of inpatient and outpatient PT rehab places, and it's not like here at all. They treat you, you know, for whatever's going on. Oh, I have a foot drop, or I sprained my ankle. It's very short term, and it's not looking at the whole person. So this is a very unique model. I've never seen anything like this, where I can go to rehab, have the same therapist. Chris, the director here, has been literally working with me for 6.5 years. You don't have relationships like that with physical therapists in the community.
I had been asking for years to have a physical therapy referral, and no one was really prepared for MS patients. In fact, I had several centers say I couldn't do work there because I had MS. Keeping up with physical activity and a guided program like they offer here is really essential. I think anytime that I've taken a break for reasons of illness or something else going on in my life, I've always had to build back up. But if I maintain, it really keeps me much better.
If I didn't come here, I think I'd be in a wheelchair at this point, and I think I would probably be a lot less mobile and a lot less active than I am. You could be proactive, and I think you have to be proactive. Otherwise, I think the illness takes its toll. I believe that if I had been limited to 10 sessions or 15 sessions, that I would have just gone straight downhill afterwards.
I honestly and truly believe that I would be in a wheelchair if it wasn't for the MS Specialty Center and all the amazing people that work here. I absolutely would be. I am so thankful to everyone that works here. Even my fellow patients, we all kind of keep each other going. I really think that this is the most amazing place.
So thank you for those remarks. Thank you, John, for recording those remarks. John's practice demonstrates how GMO, when properly implemented or followed, can help individuals with chronic conditions. We also asked John what, in his view, are some of the remaining barriers to fully implementing GMO. And John provided some written responses, excerpts of which I'd like to briefly summarize and share. John said that there's still, as Wei noted in her opening remarks, there's still much work to be done, and John's view on two fronts. To start, many therapists that follow GMO correctly are being targeted and heavily audited by some Medicare administrative contractors, or MACs. These MACs claim to acknowledge GMO in words, but in practice that is not the case. This pattern also causes many clinicians to hesitate to correctly follow GMO for fear of being audited out of existence. John states that I've seen firsthand how the GMO ruling changes lives by keeping patients out of the hospital and living safely in their homes. He goes on to note about how he has also seen firsthand that it avoids hospitalizations and can save the Medicare program significant amounts of money. Secondly, John notes that we do need a culture shift of awareness among caregivers who are in a position to follow GMO. We need more education amongst one another with regarding to GMO and how to use it properly. I'm still hearing stories from all over the country that necessary skilled intervention is being stopped improperly and that the patient is later declining. And to that point, John shared with us a message he recently got from one of his former patients who moved down south. This patient said, quote, "Since I have been down here, I've been chasing down PT as I get discharged every time after I improve. It's incredibly frustrating. I am doing very well in PT right now, so I am getting discharged. There are some things that I've done that have made me improve, but I can't do them safely by myself. I'll do things at home for a couple of weeks, then I start to decline. I'll ask my doctor for a referral for yet another place." So although we hail GMO as a success, clearly there's still a lot of work to be done to ensure that the settlement is properly implemented, a topic that we at the center will continue to push for during this anniversary year. So stay tuned. You will be hearing more from us if you would like. Now we're going to shift gears to an area that was discussed in the opening segment and which needs a lot more attention. And talk about barriers of care specific to private Medicare plans. As we heard, as of this year, half of the entire Medicare population will be enrolled or is already enrolled in Medicare Advantage plans. And in part, this is due to a growing imbalance in payment. Medicare Advantage plans are paid more than traditional Medicare spends on a given individual. Scope of coverage, Medicare Advantage plans can use that extra money to cover more than what's covered under traditional Medicare, and ease of enrollment and other factors favoring enrollment in Medicare Advantage plans, including lack of uniform federal Medigap rights to have equal access in and out of Medicare Advantage plans and Medigap plans. We are now going to hear some pre-recorded remarks from Adi Barkan, founder of Be a Hero, and why he and his organization are focusing their considerable advocacy skills on problems endemic to Medicare Advantage. Now, when the history of the Affordable Care Act is written, there will be a chapter devoted to Adi and his defense of the ACA when it was under threat during the last administration. We are honored that Adi and team are now focusing their attention on Medicare Advantage. Can we hear Adi's remarks now, please?
It is great to be here with you all today. Thank you so much to Judy and the Center for Medicare Advocacy for including me in this year's summit. My name is Adi Barkan. 7 years ago, I was a healthy, 32-year-old lawyer at the peak of my career fighting for economic and racial justice. My wife, Rachel, and I had just brought our chubby, happy newborn home to Santa Barbara. We could see decades of happiness stretching out before us. And then overnight, I was handed a death sentence. I knew that the U.S. healthcare system was broken before I was diagnosed with ALS, but having a serious illness clarified the cruelty of our profit-driven system. ALS is a progressive, degenerative disease that puts into perspective how time is the most valuable resource we have. And yet, so much of my and my family's time has been wasted on the phone with my health insurance company, navigating the infuriating bureaucracy set up to deny us care. My insurance denied me a ventilator, stating that it was experimental. 2 weeks after that, they rejected access to an FDA-approved ALS drug. Today, I am hooked up to a ventilator and rely on 24-hour home care to survive. I can only afford home care because I successfully forced my health insurance company to pay for most of the costs. It shouldn't take a team of lawyers, an experienced activist, and the generosity of friends and strangers to get the health care you need to survive. The years I've spent fighting for health justice since then have shown me that although my story is tragic, it is not uncommon. The United States spends 18.3% of its GDP on health care. But while corporations get rich, patients suffer. Over 28 million Americans are uninsured, but among those insured, many cannot afford to access their health care due to high premiums and out-of-pocket costs. 17% of all in-network insurance claims are denied. 18 million Americans struggle to pay for medically necessary prescription drugs, with 1 in 10 Americans skipping doses to save money. Between 2018 and 2022, my organization, Be a Hero, worked at the intersection of elections and policy advocacy to promote the idea that health care is a human right, and that Americans deserve elected officials who are committed to fighting for that right. Late last year, we were searching for our next campaign. How could we possibly make even a dent in the massive walls of the medical industrial complex? As we were learning about Medicare Advantage, we came across a quote from one David Lipschutz, at the Center for Medicare Advocacy. We reached out in December, and it has been the start of a beautiful friendship. As you know, America's cherished Medicare program covers 60 million seniors and people with disabilities. 25 years ago, Congress created Medicare Advantage, a program that allows private insurance companies to offer Medicare coverage, and to be paid by the federal government for each person that they insure. The Medicare Advantage program was created with the false promise that the private sector could reduce costs by better managing care. But the quest for ever-increasing profits by the health insurance corporations offering these plans has been insatiable. Through profiteering, including the strategy of upcutting, corporations offering Medicare Advantage plans are being overpaid by taxpayers between $23 and $75 billion every year. Medicare Advantage is such good business that Humana even announced recently that they are getting out of the employer-provided insurance business so that they can focus on growing their Medicare Advantage market. For years, the Center for Medicare Advocacy and other organizations have published reports that have exposed that customers on these plans frequently face improper claims and prior authorization denials or find themselves paying out of network costs because the plans do not have sufficient in-network providers. And, recently Stat News reported that these plans use artificial intelligence algorithms to deny people care, medical doctors actually reviewing claims individually as required by law. These problems will only be exacerbated as the Medicare Advantage enrollees age and people's health care needs increase. Earlier this year, the Biden administration proposed some modest changes to how these plans are paid. In previous years, health insurance corporations have enjoyed generous year-on-year increases in plan payments to the tune of up to 8% in 2022. The insurance industry has pulled out all the stops and poured many millions of dollars into framing this as a cut. They have bought off gross-stops worker associations, providers, and patients to lobby Congress and the administration and constantly run ads to scare seniors and people with disabilities, including a well-placed deceptive Super Bowl ad, paid for with taxpayer dollars. The final rules just came out. The insurance industry's pressure worked, at least partially. They have delayed the new payment formula, and are surely planning to push for more delay, maybe even with a more friendly administration. But, nevertheless, the rules are a good start. Thanks to increasing media scrutiny on this issue and important work by organizations such as Center for Medicare Advocacy, the reputation of the Medicare Advantage program is shifting rapidly, and a number of elected leaders are asking hard questions about whether or not taxpayers are getting our money's worth. and shining a light on how too many elders and disabled people on Medicare Advantage plans are not getting the care they need and deserve. Despite these efforts, this year, we will cross the threshold of more people being on Medicare Advantage plans than actual Medicare. But given that more and more elected leaders are looking into this and asking questions, we have an opportunity to create more room for reform and make Medicare a truly great public program. We can actively promote and endorse legislation to level the playing field between Medicare Advantage and traditional Medicare. We can campaign to enact out-of-pocket caps in traditional Medicare that is on par with Medicare Advantage plans. We can expand federal Medigap rights for younger people with disabilities, and allow patients to easily switch between Advantage plans and traditional Medicare plans. And we can expand vision, dental, and hearing to all beneficiaries. And we must continue to work together to get the fraud and profiteering out of the Medicare Advantage program and penalize the corporations that do not provide care and violate their obligations. We at Be a Hero are new to the issue of Medicare Advantage, but we aren't new to organizing on healthcare issues. We are approaching the work informed by our experience in advocacy and organizing, and informed by the history of social movements in America. That history shows that major change is possible, even in the face of incredibly powerful opposition, when large numbers of people demand it. Thank you again for inviting me to speak today, and thank you for your decades of work and leadership on these issues. I look forward to working with all of you to make these policy changes a reality and make Medicare the public good that it was always intended to be.
Adi and team, who we believe are watching online, we thank you for your remarks and we thank you for your partnership. So, Rachel, in Adi's remarks, he highlighted in part how some policymakers and members of Congress are starting to ask the hard questions and are starting to look with more scrutiny at the Medicare Advantage program. Your boss, Congresswoman Jayapal, is playing a lead role in doing this. Could you talk to us a little bit about why she's doing this when so many other policymakers have turned away and have refused to ask these hard questions?
Definitely, and thank you so much for having me. I'm really excited. I'm always excited to talk about Medicare and how we can make it better. So, Congresswoman Jayapal's interest in fighting Medicare privatization and really making sure that Medicare is working as it's intended comes from a core goal of hers, and that is to improve and expand Medicare. And this is through a variety of different policies, including through Medicare for All, which she's the lead sponsor of, but also through other policies that we could attain much sooner. Like, and these are things that Adi mentioned, expanding benefits to include dental, vision, and hearing, because the Congresswoman, and I think a lot of people in this room, don't understand when our teeth, our eyes, and our ears got separated from our body when we think about healthcare. But we really need to expand those benefits. Other things that we can do to improve Medicare would be lowering the Medicare age once we make the improvements and make sure that it's working as it should, establishing an out-of-pocket cap for all Medicare beneficiaries. And when we talked about these things, the last big opportunity to make these changes came during the Build Back Better negotiations. And much of what we were talking about in that bill and all of the things that I just mentioned were thrown around when talking about how do we improve Medicare in that bill. But a lot of it came down to cost and top line numbers and things like that. However, at the same time, there's a very large pot of money that goes to Medicare Advantage companies. Adi just mentioned it. We pay anywhere from $20 to $75 billion per year in overpayments to Medicare Advantage companies. So we are putting enough money into Medicare to make these improvements, to make these expansions. We're just putting it in the wrong place. We're putting it into Medicare Advantage companies' pockets, frankly. And so that really didn't sit right with the Congresswoman, because that came at a time when we were also hearing a huge increase in patient stories about how they were being harmed by their Medicare Advantage plans. And you've heard it earlier today, we just heard it in Audie's remarks, but a lot of people were starting to come out of the woodwork very bravely to talk about a very personal issue, their health, and explaining how care was being delayed and denied very inappropriately by Medicare Advantage companies. They were having to pay very large sums of money that they did not expect because benefits that they needed and that should have been covered under Medicare were not being covered by their Medicare Advantage companies. And the Congresswoman also heard from a lot of folks who felt very misled and in some points harassed by Medicare Advantage telemarketers, misleading advertising, things like that. And this really led to the Congresswoman wanting to get involved not only to reform what's going wrong in Medicare Advantage, but to use that as a way to improve and expand Medicare for all beneficiaries. Because again, we shouldn't be funneling a bunch of money into Medicare Advantage that's never actually benefiting the patients and the beneficiaries. So this led the Congresswoman to lead a few letters to the Biden administration urging them to make different Medicare Advantage reforms. Now, the latest one of these letters had a total of 70 members of the House of Representatives on it, and it urged 4 key reforms, which I think have all been laid out earlier, but I'll just run through them. We wanted the plans to stop inappropriate delays and denials of care through both prior authorization but also step therapy in Medicare Part B, which is the practice of making a patient fail first at using a cheaper drug before they get the drug that the patient actually needs. We also urge them to stop restrictive provider networks. Research has shown that actually the top cancer centers in the country are overwhelmingly not included in Medicare Advantage networks. And so we have seniors and people with disabilities who need cancer care and are automatically not able to get the best care that's offered because of their Medicare Advantage plan. The third ask was to stop those overpayments to Medicare Advantage companies. And the fourth ask was, let's reinvest all of that money so that we can make Medicare the program that we know it truly can be and it was intended to be. And we were very excited to have so many members sign on to this letter because it really marked a shift in the dynamics around Medicare Advantage in Congress. And this, I think, is the product of years and years and years of advocacy by Center for Medicare Advocacy and so many other groups who have been working for a while and raising the alarms on Medicare Advantage for so long. However, it was very much considered as something you don't touch, like I talked about the pot of money over there that you don't want to touch. I think 2 things really led to the shift in those dynamics. And one, again, is the deep educational effort that has been happening outside of Congress as well as inside of Congress. And the Congresswoman held a Congressional Progressive Caucus meeting with all of the members of the Progressive Caucus, which is over 100 members of the House, to really sit down and talk about what's going on in Medicare Advantage. And we were amazed at the amount of engagement that we got at this meeting. We had members who were staying late, which does not happen in Congress. Usually you're running out early to the next thing. We had members who were just outraged at what was actually happening in Medicare Advantage and asking, what can we do? What should we do about this right now? I think another part of the shifting dynamics is that we have seen increasing profiteering from Medicare Advantage companies. The amount that they are upcoding has increased. The amount that they're denying and delaying care, the new ways they're finding to do that, like Audie just mentioned, now using artificial intelligence to cut off care to people who need it. It's increasing to a point that we are hearing so many folks who are coming forward and saying, I have been hurt by my Medicare Advantage plan, and they're reaching out to their members of Congress, they're reaching out to senators, folks in the House, things like that. And I do think we're, if not at it, we're close to a tipping point where Medicare Advantage companies have taken it too far and the harm that they're causing is overflowing. And so it's been really exciting to watch and to work with a lot of the other members in Congress who have been raising these alarms. There's a small group that we're excited to be working with, including, Representatives DeLauro, Schakowsky, Doggett, and likely a few others that I'm forgetting. So there has been a core group, but it's definitely growing, and it's growing really quickly. And I think it's due a lot in part to the Center for Medicare Advocacy, and also the bravery of people who are finally stepping forward and saying, I'm on a Medicare Advantage plan and I couldn't get screened for my cancer care. I couldn't get my biologic medication that would have cured my cancer because they wanted me to try chemo first instead and things like that. So I'm really excited just to be talking about it with all of you, and excited to see where this goes, because I think this year with the Biden administration's rule for Medicare Advantage, we did see, although it didn't go as far as we wanted, the first acknowledgement that Medicare Advantage companies are upcoding, are gaming the system, because the administration is trying to change it. And I think it marks a real tipping point, and I'm excited to continue working with you all. And I know the Congresswoman is too, to see where we can take this.
Thanks so much, Rachel. We can't tell you how thrilled we are that these issues are finally getting attention on the Hill. It seemed that wasteful spending by the government was something that would get the attention of any lawmaker, but for some reason, Medicare Advantage and overpayments were untouchable. And it's wonderful to see attention on that. So given that Congress is very closely divided at the moment, do you foresee any pathways towards addressing some of these issues, either in the short term or in the long term? You mentioned Build Back Better a couple of years ago, where we had significant hope of expanding Medicare coverage, but that fell short. What is realistic in the short term and maybe a little longer term?
That's a great question. I think in the short term, as you mentioned, it's a divided Congress right now, but the growing realization that we need to do something on Medicare Advantage is growing very quickly on the Democratic side, where Congresswoman Jayapal is, but I'm also seeing signs that it may be growing a bit on the Republican side, and I see that in the introduction of a bill called the No Upcode Act, which is a bipartisan bill led by Senators Cassidy and Merkley, and that would tackle a lot of the Medicare Advantage profiteering through the risk score gaming. It's bipartisan. It was just introduced, so we don't know what the future of the bill is going to look like, but even to have someone, a bill with someone from both sides of the aisle, I think is a significant step forward. I also think it will be very interesting to see what happens as we navigate the debt limit situation right now, because I think we have folks who are looking to make cuts, and there's a very obvious cut to us, and that would be cutting the overpayments to Medicare Advantage. That would save, again, tens of billions of dollars a year. And when you compare that to something like a Medicaid cut, a Medicare cut, different than Medicare Advantage, cutting benefits, the pros of cutting the Medicare Advantage overpayment is we're not actually hurting beneficiaries. We're not even touching the benefits that they will get. Research has shown when there was a similar check on the Medicare Advantage overpayments in the Affordable Care Act, the Medicare Advantage companies put out their scare tactics. Premiums are going to rise. We're going to cut benefits. But research shows they actually didn't do that. And so I think it will be interesting to see if this Medicare Advantage issue has a place in the debt limit conversation. We're certainly trying to make it have a place there. And I'm seeing some interesting signs. And then one other thing I'll mention that's not directly related to Medicare Advantage that I have seen a lot of growing bipartisan interest in is site neutral payments for Medicare, which folks are also looking at to decrease the price. But I think we're still, pushing fully ahead on Medicare Advantage reforms, but it may be a little while until we get there. In the long term, I think, an overwhelming majority of the Democratic caucus supports the improvements and expansions to Medicare that we're trying to make. And more are coming on every day to let's stop Medicare Advantage overpayments to reinvest that money. So I think that's what the outlook holds.
Right. So the word Medicare is in the name of our organization, but we also care about Medicaid, as do a whole bunch of people in this room and watching online. Given the speaker's budget proposal issued yesterday, is there anything you'd like to say about the Medicaid proposals or provisions in there?
Definitely, and I'm going to repeat myself a little bit here, but the proposed requirements for Medicaid are going to be very, very harmful to a lot of Medicare or Medicaid beneficiaries, excuse me. And research has shown that these types of requirements lead to folks being disenrolled from Medicaid at a very high rate. And the worst part is it's not because a majority of them don't meet those requirements. It's the paperwork burden. And you have to have a computer often with Wi-Fi to be able to fill out your paperwork and certify that you're meeting the requirements. And we're just building even more barriers to care, which is what this panel is talking about. And so I think it's going to be detrimental. And again, to the Congresswoman and to our office, there's a very obvious alternative. And again, it's stopping those overpayments to Medicare Advantage, which is a savings that we will be able to attain very, very easily without hurting anyone.
Thank you, Rachel. So in your remarks, you very clearly pointed out kind of the macro threats that the Medicare Advantage program has on the Medicare program writ large. And that includes pressure that these overpayments are putting on the trust fund, and the fact that this overspending crowds out other expansion in Medicare coverage, such as vision, hearing, dental, or an out-of-pocket cap. You also touched on impacts to the individual enrollees in the form of prior authorization and denials. And earlier, Tricia outlined some of the data around some of the prior authorization denials and the rampant use of prior authorization. And before we get off of Medicare Advantage, I was wondering if you could tell us a little bit about what we as an organization see with respect to Medicare Advantage and prior authorization, given the fact that people don't call us when their care is coordinated well in a Medicare Advantage plan. Rather, they call us when they run into problems accessing care. So, Wei, could you give us an example or a taste of some of the things that we see in that area?
Sure. What Rachel and Adi said is very consistent with what our advocates are hearing from beneficiaries and also providers. I had a provider tell me that when a patient is sent to their rehab facility after a hospital stay, that if that patient has Medicare Advantage, they pretty much know right away, just on day one, that that patient's only going to get 14 days of coverage from their plan. So it doesn't matter, regardless of what the treatment plan is, or if the patient is still in pain from their surgery or suffers a setback or maybe has a condition that hampers their ability to make progress, it doesn't matter. Expect to get a denial letter before day 14. And at the center, we're also finding that more and more that these denials, these decisions are being handled by post-acute management companies like Navi Health and MyNexus, which use proprietary AI-driven algorithmic tools to make these decisions about how much care a patient needs. We know that when beneficiaries appeal these denials, and let's say they win, they pretty much get smacked with a new denial within 2 or 3, 5 days. They get another denial. The most astounding case we heard about was a woman who had an 81-year-old woman, hip surgery, basically appealed 10 successive denials before she contacted us. I mean, can you imagine having to fight 10 denials for one course of treatment? I mean, it's awful. But we also, based on our experience, we also know that the vast majority of people do not appeal because, these decisions that they receive are very conclusory, they're intimidating, and they're coming at a time when patients are recovering, and it's just incredibly stressful. This idea that they, if they lose the appeal and they stay, in the nursing facility, they'll be on the hook financially, and that's just not something, a burden they can bear. So most people we know just go home and they make do with the truncated care that they received.
Thanks, Wei. So Rachel, you had mentioned kind of a shift in tone towards Medicare Advantage on the Hill. That, in our view, has also occurred amongst providers of services, particularly since last year's Office of Inspector General report that built on an earlier report looking at Medicare Advantage denials. More and more providers are speaking out about frustrations and problems with Medicare Advantage. And we asked John Marmaru, from whom you heard earlier, a PT, about his thoughts about whether or not there was a difference in treatment and care authorized by Medicare Advantage plans. And after he got finished writing about problems he saw with marketing and people being inappropriately enrolled in such plans and then finding that their care was not covered, he said, more importantly from his clinical perspective, he said, quote, "My experience as a clinician with MA is that they create barriers to necessary care and often shift a lot of the costs over to patients. MA plans are required to cover what traditional Medicare covers, but that is not what myself or my team have seen in practice." There's clearly a lot more work to do in this area. CMS just released a final rule. In addition to the payment rule, they released a final rule having to do with Medicare Advantage in Part D, which included some provisions pertaining to Medicare Advantage prior authorization. And it's clear in this rule that CMS intended to try to curb some of this misconduct. There's some very good language in there that we hope will help, but as with anything else, a lot of it comes down to whether or not the plans are going to comply and whether or not there's going to be oversight and enforcement on the part of the regulator. So I want to pivot yet again. We've talked a little bit about JIMO. We've talked about Medicare Advantage. Wei, I'd like, if you're willing, to discuss a couple of other barriers to care that we have tried to address over the long haul. And you can talk a little bit about what those barriers are and how we've tried to address it. And one of them is the lack of oral health coverage for people in Medicare. The other is challenges accessing home health care, particularly home health aides. And as we heard from Trisha's setup earlier, many Medicare Advantage plans do cover some form of dental care. However, it is not required and it is not standardized and varies considerably. Often has an out-of-pocket dollar cap. Sometimes there's a cleaning or two per year. In other words, it's a very skimpy benefit for dental coverage, if at all. So where's the barrier to care here and what progress has been made?
Okay, thank you. I love talking about dental. That's dear to my heart. So the cost of dental care is just prohibitive for many Medicare beneficiaries, including many who are on Medicare Advantage and have dental benefits through that program. And that is why the center, in broad coalition with partners like Henry Schein Cares and Santa Fe Group, have been fighting for legislation to include a comprehensive dental benefit in Medicare Part B that would benefit everybody in Medicare. And we actually came pretty close to that back in 2021 with negotiations around the Build Back Better Act. But when that opportunity came and left, we then shifted to the agency and really, imparted on them that they could make a real difference by at least expanding coverage for medically related dental services. And we had kind of a victory at the end of last year with that. So CMS agreed to recognize that payment could be made for dental services that are integral, inextricably linked to a to the success of a covered medical treatment, and specifically basically said payment could be approved for dental exams and also treatment of infections, dental infections in the context of solid organ, stem cell, and bone marrow transplants, as well as cardiac valve surgeries. So now we're in the situation where we have some expanded payment there, but the problem is we don't have enough dentists who are enrolled in Medicare to be able to provide that care. So that's another issue we need to tackle for implementation.
So how do we get more dentists? Is there anything that CMS can do?
Well, one thing off the top of my head is, so thinking about how dentists, currently dentists are required to formally opt out of Medicare in order to prescribe medications like antibiotics or imaging to their Medicare patients. And so that's a problem. They're formally opt out. But the agency has allowed an exception for those dentists who serve Medicare Advantage patients. So we hope that the agency could similarly allow an exception so that dentists could provide this medically necessary care.
Great.
And we've asked them to, of course.
And then could you talk a little bit about access to home health, in particular home health aides?
Yes, so we've been very concerned about the fact that Medicare beneficiaries just cannot seem to be able to access the home health aid services that they are entitled to under the law, and especially people with chronic and disabling conditions cannot get the amount of aid services that are under the statute. And Medicare, when it was legislated, Congress recognized the importance of aid services to keeping people at home and out of institutional settings, and therefore provided for between up to 28 hours, or in some cases 35 hours per week of combined nursing and aid services. But that is just, people are not able to get that nowadays. Over the past 25 years, there's been such a steep decline in the provision of aid services. Right now, aid services account for only 5% of the home health visits that are furnished to people. That's a 90% drop since 1998. And MedPAC has, in recent years, says that the average person who's getting services gets less than one aid visit per month. So I don't know how people manage on that. So we, last year, the Center for Medicare Advocacy filed a federal suit entitled Johnson versus Becerra, asking the court to order the agency to administer the home health benefit in a way that does not discourage home health agencies from furnishing aid services to individuals with chronic and disabling conditions and placing them at risk of institutionalization. This lawsuit was brought on behalf of two organizations that help people with ALS and multiple sclerosis, and also on behalf of two individuals who have quadriplegia and who have suffered considerable physical, emotional, and financial hardship because they have been repeatedly denied the aid services that they are eligible for and qualify for. Unfortunately, last month, the court in this case dismissed it, finding that the plaintiffs lacked standing, finding that it was just too speculative that a court order could actually redress their injuries. And so we are now weighing our options on what to do about that case.
Thank you, Wei. So yet another example of where the words don't match up with the actual rights. So we've touched on just a few of the many barriers to care in Medicare and talked about some of the ways to combat them. Legislation, litigation, there's also raising media awareness. We look forward to continuing to work with all of you on addressing these issues. I would like to thank Rachel, Wei, John, and Audie, and thank all of you for your attention. Thank you. Yes, I have one. Thank you.
I want to thank you all so much for this inspiring, though worrisome panel. And we will be visiting your office, I'm sure, Rachel, to increase the numbers on that letter from 70 to 140 to 200 to make it clear and, that we should invest in Medicare, which serves all people, not just those who are choosing or wrangled into Medicare Advantage plans. I want to thank Peter Thomas and Powers Law Group for helping to sponsor this panel, as well as Amy Niles and the PAN Foundation. I want to thank Peter for many things, but we're very grateful to you and your law firm. Also, we are very sorry that Senator Rockefeller is not feeling well and got a call. He's not up to coming this afternoon, but we will be having an exciting lecture when we reconvene. The last thing I want to do before our break, this is also somewhat of well, this is a big community affair. This is a community activity, as you know. We are very proud of building the Center for Medicare Advocacy's community. To those out there in TV land and to those in the room. And at this time, I just want to take a very few moments to say a special thank you to some stalwarts who are not presenting today. First to Kathy Holt, who is our Associate Director in the Connecticut office. You heard from Wei. We are really advocates for care at home. You heard some of the problems in the lawsuit we brought. We only bring those lawsuits when we must because it's incredibly resource intensive. It's not the way to run a railroad, but people cannot get the care they need, as Regina said. People cannot get the home care they are eligible for under the Medicare Act. So I'd just like you to stand for a moment, Kathy, who's our home health leader. So passionate and devoted to moving this issue forward with her colleagues. Allie Bears, who is unfortunately suffered her concussion, isn't here today. She is the director of litigation for the center, and she and Wei talk about us being a small but mighty. Our litigation team is barely, well, we're not 3 full-time FTEs, and we do all we can with this very small but mighty crew. Allie is extraordinary. You may know that she's also the lead counsel in a case called Bagnall, in which we've been kind of in the Charles Dickinson way, litigating for 12 years with friends from Justice and Aging. I know Jennifer and Regan are over there. I want to say a special thanks to Wei for her extraordinary help with litigation, with home health, with oral health for the Wei memo, and to Allie Bears for leading our litigation work. Allie, I hope you're listening, and we hope you hear these applause. Just a few more. We don't have time to include nursing home residents' rights in today's program. Toby Edelman is the woman who helped bring the nursing home reform law to reality and is still, though these many years later, trying to make it reality. for the life of those who live in nursing homes. And we thank you immensely for your legal acumen and incredible stamina. Thank you very much, Toby. Finally, in absentia, Mary Ashkar is an attorney who leads our Medicare Duly Eligible project. She is intrepid, she is brilliant, she knows more about Medicare appeals, ALJ cases, for both Medicare Advantage and traditional Medicare in the home health and nursing home settings. She is undersung and deserves a loud song. So let's sing a song for Mary. Thank you. And finally, I hope you will look in your folders at the memoriam for Mike Klug. Mike was a leader in Medicare advocacy for many, many years, almost as long as I. And he passed away in March, much too early, from pancreatic cancer. And during the last year, he's been stalwart as ever, working on some Medicare cases, seeing if he can help us with some. Can we help him? And also holding some video lectures about his blessed Chartres Cathedral. So we wish Merce and his wife Merce and his daughter Cora well. And I want to thank his many, many friends around the country who donated over $3,000 individually in his memory to the Center for Medicare Advocacy. So we are a family and a community, and we hope you will have a nice stretch, break, and rejoin us at 2:55. I know it's abbreviated, but you'll want to hear from Teddy Kennedy Jr. and before him a few early remarks. Thank you so much. We're going to get started, please. Everyone, please come on in. We've got a very important part of the program, as all the other parts have been, of course. Can you hear me on the mic? I have a feeling the mic may not be on, but Derek can help that. It is? Okay, thank you so much. There we go. So we are going to begin the Rockefeller Lecture component of the program. It's the 10th anniversary of both Senator Rockefeller's retirement from the Senate and beginning of gracing us by allowing us to name a lecture in his name. He gave the first lecture, and Judy Fader, our esteemed chair, gave, I think, the second lecture. Judy's going to help me from the floor with some questions for Ted Kennedy, and I'll introduce him in a moment. I want to ask Scott Bain to say a few words. Scott and Nancy Wexler is here too, Nancy, from the John A. Hartford Foundation. We at the Center for Medicare Advocacy have been graced with funding from the John A. Hartford Foundation for a number of years. Now they have truly given us the gift of general operating support. It means that they have it shows how much this community, not just from the center, knows the value of that kind of funding. I hope you'll bring that message back to your board.
You just did.
And in addition, they are supporting with their grants this lecture. So Scott Bain is our program officer. He is many things, including a published author of a wonderful book, and as well as an attorney and the kind of program officer you want for a grant that means so much to your organization, because he's always got an idea, he's always supportive, and has ways and means of thinking how maybe we could do this together, or maybe we could do that. And I'm so glad, Nancy, you're part of that endeavor now, too. Scott?
Thank you, Judy. That's for those very nice remarks. And we, both Nancy and I, are so happy to be here this afternoon with all of you. And it's so nice to be here for the 10th anniversary and to be back in person. I want to, first of all, congratulate the entire team of the Center for Medicare Advocacy for your tireless work to advance access to comprehensive Medicare coverage, health equity, and quality health care for older adults and people with disabilities, as we were talking about earlier. You are advocating for real people in real time with real consequences. And for that, we all are incredibly grateful. And thank you to everyone attending today, from our elected officials to representatives from the Centers for Medicare and Medicaid Services, but once again, most importantly, for everyone with a red, white, and blue Medicare card in your pocket at this very moment. It's for you that the center is working. A little bit about the John A. Hartford Foundation. We are a national philanthropy based in New York City, and our mission is to improve healthcare for older adults. We work today in 3 priority areas: building age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And because of that, our mission is very aligned with that of the Center for Medicare Advocacy. For example, the center has been a fierce champion for nursing home reform, and that is a major focus of ours at the foundation. We have partnered with the Institute for Healthcare Improvement and have recruited nearly 500 nursing homes into the age-friendly health systems movement, which is focused on quality improvement to reduce harm and focus on what matters most to older adults and their families. The foundation also supports the Moving Forward Coalition, which counts more than 900 participants, and staff from the Center for Medicare Advocacy participate in that. The coalition is mobilizing policy change to address systemic problems that are far too pervasive in nursing homes. We invite you to learn more about this at movingforwardcoalition.org. So let me just close by thanking the Center for Medicare Advocacy, whether it's fighting for access to home health care, ensuring that consumers receive accurate, balanced information about traditional Medicare and Medicare Advantage, or work on nursing homes. The center is laser focused on equity, quality, and age-friendly care. So we urge everyone to join us in financially supporting the center today. Seriously, working together, the center is making Medicare better for all of us as we age. Thank you for being here today.
Thank you, Scott. I don't know if it's appropriate to give funders presents, but thank you very much. I have to make sure I have my notes for you.
You don't need
them. I'm really very honored to be able to introduce this year's Senator J. Rockefeller Lecturer. And I want you to know that, about an hour ago, we got a call from his administrative assistant, who some of you know has become quite a friend to the center and to me, and Mrs. Rockefeller. The senator had every intention of coming today, but some days are better than others for him now, and he won't be able to join us. But it was with great enthusiasm that he wondered whether Ted Kennedy Jr. could give this lecture. And finally, our dates met, Ted. And yet, the senator isn't here. Ted Kennedy Jr., as an amputee and childhood bone cancer survivor, has been an active leader in the disability rights and independent living movements nearly his entire life. He's a board member and immediate past chair of the American Association of People with Disabilities. I have to say that's one of my favorite titles, immediate past, whatever. Immediate past. One of the nation's preeminent civil rights and public policy organizations dedicated to social reform and equal rights for people living with disabilities. And Ted's going to really focus more today, as you've heard our discussion talking about people living with disabilities, about the civil rights involved and how we do or don't recognize people with disabilities in the civil rights movement. He is co-chair of the Disability Equality Index, DEI, the leading corporate social responsibility, accountability, and benchmarking tool that tracks businesses on their disability inclusion policies and practices. And he's also a healthcare regulator, attorney, and partner at the national law firm Epstein, Becker, and Green, where he counsels many of the nation's foremost healthcare companies. I'm very proud to say that from 2015 to 2019, I occasionally ran into Ted at the state legislature in Connecticut as he was a state senator, and finally was really Senator Kennedy. And I guess not saying you confused me with my father, right? He passed many and numerous healthcare reform laws, expanding home and community-based services, price transparency, and mental health parity. Connecticut stands forward in these areas, in part because of Ted and his family's work. He currently also, I'm proud to say, serves on the advisory board of the Center for Medicare Advocacy. Ted Kennedy.
Thank you.
Ted asked us to handle this as kind of a fireside chat, and so I'm going to try and do that, but we don't have a fire, but we're going to hear from Ted and then have a bit of a chat, and I hope as you're listening, you'll think of questions to join in the discussion.
Well, let me first say thank you to you, Judy, and to the entire staff of CMA for continuing to coordinate this national meeting and for all the work that you do day in and day out to ensure that every single American under the Medicare program has access to the best health care that they deserve. So thank you. I take my hat off to you and to the staff of the Center for Medicare Advocacy. Secondly, I want to say how much respect and admiration I have personally for Senator Rockefeller and the entire Kennedy family holds Senator Rockefeller in such high esteem. Obviously, he served alongside my father for many decades in the United States Senate, but he also started his career working with Sergeant Shriver in the 1960s,
Right.
building the Great Society. So his whole life has been devoted to advancing equality, justice for all people in our country. And I think we should just give a round of applause in absentia for Senator J. Rockefeller.
He may be watching. I hope he's watching.
So it's a privilege and an honor for me to be asked to give this lecture. You know, when Judy asked, would you give a lecture and I said, well, how long a lecture do you want me to give? And she said, well, typically we talk for 45 minutes or about an hour. So I said, I think that is too much to ask your attendees to sit for an hour listening to me talk. Let's do a fireside chat where we can cover the ground of and explore together. You heard from my introduction. I spend part of my time as a healthcare regulatory lawyer at Epstein Becker Green. I've been a healthcare lawyer for over 30 years. And I also have been a lifelong advocate as a pediatric bone cancer survivor, amputee, lifelong advocate for the civil rights of people with disabilities. So I am very interested in the topics that the Center for Medicare Advocacy delves into, which is, because I have one foot in healthcare, one foot in disability rights, and that's really what the focus of this meeting is today, is ensuring that people with chronic conditions and individuals with disabilities who are in the Medicare program have access and don't get unfairly denied the care that they need. And so I think this is a great opportunity for us to explore many of these issues together. But I was particularly happy to be here because I was speaking at another conference a few months ago and was leafing through some of the brochures on the table, and I opened it up and I looked this is about 10 minutes before I was going to be invited to the podium, and I looked down and it said Ted Kennedy Jr. Speaker Evaluation Form. Now, if any of you have ever asked to present at a seminar or have to give a lecture, that's the last thing you want to see as you make your way to the podium. And some of these were actually shared with me recently, and I'll never forget this one. It said, if I had only an hour to live, I would choose to spend it at one of your presentations. And I thought, that is the nicest thing I've ever heard, except there was a little arrow instructing me to turn the card over, which I did. And it said, because only at one of your presentations does an hour seem like an eternity. So I am particularly grateful that we're making this a fireside chat, because that way we can make this inclusive. And let me just say a couple of brief introductory remarks to just talk a little bit about how I got involved in this issue, what I think the goals are in the disability rights community. Judy and I have spoken repeatedly over many years now, trying to forge alliances between, and that's what you're all about. That's what CMA is all about, trying to form alliances with different groups that have similar interests, similar goals. And I think the disability community has a complete alignment with the work that this organization is doing, because, of course, so many people with disabilities face healthcare issues. experience extreme economic inequality, social isolation, continued challenges accessing the healthcare system. And there's so many, the Jimmo case, which we're celebrating today, had a profound impact on individuals with disabilities and their ability to live independently. So there's so many different areas that we can work on, and hopefully, you know, this will just be one of those times where we can hope in meetings, so many of you here continue to come up with ideas about ways that we can work together. But I was thrust into this issue when I was only 12 years old. Some of you may know my story. I'm a pediatric bone cancer survivor. I lost my leg 12 years old and in 1973. And I remember, one of the things that I remember is one of the boys who was getting his cancer treatment next to me, he had also lost his leg to osteosarcoma. And I kept on seeing him periodically over the course of 18 months or so. And I asked him one time why he didn't wear an artificial leg, because I knew that for many people, it's painful to wear an artificial leg all the time. And I asked him, you know, is it hard for you or painful? And he said, I would love to wear an artificial leg, but my parents can't afford one. And I remember it was really probably one of the, look, I knew I had always grown up with incredible privilege and you know, but that was like an extreme shock to me. That, and I thought about the unfairness of it all, about why is it that I was able to get a leg and this child was not. And I remember at that time, I said to myself, I was only 13 years old, but I said to myself, one day I want to do something about that. I didn't know what I was going to do. I had no idea how to do it, but I knew that there was some unfairness there. And so that's why I became a healthcare lawyer, and I ran for public office, as Judy just said, in the state of Connecticut, and left to go be the board chair of the American Association of People with Disabilities. And so anyway, we are obviously fighting to ensure that people with disabilities have the same rights as everyone else. And another one of my two other initiatives that I'm involved with, and including the work I'm doing in healthcare, is one, which is the Disability Equality Index that Judy mentioned, which is the DEI, which is now the leading corporate benchmarking tool for disability equality and inclusion. So yes, we are starting to measure and benchmark and score and grade companies based on what they're doing to advance individuals with disabilities within their workforce, across their enterprise, many, many different measures and metrics about how we evaluate companies, identify the companies that are doing a good job. And so, because we know, like the Center for Medicare Advocacy, you know, we've litigated in courtrooms, we've passed laws. We know, even though the ADA is 30 years old, we still are faced with enormous challenges. People with disabilities left out, can't get a job, no transportation, intertwined with poverty, which means that there's food insecurity, housing insecurity, no transportation. All of this impacts people's health care. So even though we have an ADA that's been around for over 30 years, we still have these challenges. So we need to start thinking about new strategies. And so, yes, we've litigated in cases and, again, passed legislation all over the country, but we need to find new strategies too, which is why we want to engage our corporate partners who share our views. And plus, the reality is that individuals with disabilities, and I include older Americans, we know 40% of all people in the Medicare program now have a disability or chronic illness. So we are talking about, this is not some, you know, small group of people. These are many, many people, and it's growing every day because as our country ages. And so, you know, people want to know today, you know, where they buy their coffee, what toothpaste they use, what airline they fly on, where they do their banking. They want to know, do these companies share my vision for a more just and equitable society? So I'm on a mission to make disability, equality, and inclusion the next chapter of ESG, corporate social responsibility. I'm working now with 30 of the largest pension plans in the United States, from the state of Hawaii to CalSTRS, the large teacher plan in California, to Illinois, New York, Pennsylvania, Massachusetts, many other faith-based organizations and other companies using their power as shareholders to advance disability, equality, and inclusion. And although we're getting a little pushback because, ESG is now, I guess, can we even talk about that? But we're interested in the S, the social. But what we're finding is that the companies that are leading on disability inclusion are outperforming. They have 30% higher profit margins and 4 times more likely to outperform their peers.
I see a few people who'd like you to explain ESG a little bit more.
Environment, social governance. These are evaluating an organization's sustainability based on environmental, social, and governance factors. And that's where a lot of many investors, people who invest in companies, want to know, broadly, how you treat your workers. Are you destroying the environment as you produce the product that you sell? What kind of corporate citizen you are, et cetera. And what we specifically measure is disability inclusion. So we want to make sure that as we talk about diversity and inclusion, as important as that is as part of our national conversation, most people think about that in terms of ethnic, racial, gender, LGBTQ+, veterans, that kind of thing. We want to make sure that people with disabilities are also included in that national conversation on diversity and inclusion. I don't want to get too far off track because I know you have some questions for me. And you know how I know that, Judy?
Yes.
What?
Because you sent me some.
Oh! I said, Judy, there's one thing I don't like. I don't like surprises, okay? So Judy's like, I'm not going to invite you to come speak to my friends in Washington, D.C. and surprise you, Ted. So I said, no, we've talked about the many ways that people with disabilities can be disfavored by the current healthcare delivery system. We've talked about how poverty is probably the biggest impact, and how individuals with disabilities disproportionately are impoverished and lack the basic food, transportation, housing that impacts their health. So you'll find that whether on so many different metrics, whether things like diabetes, arthritis, heart disease, high blood pressure, cervical cancer, breast cancer. Why? Women with disabilities do not get mammograms or cervical or pap smears or other types of tests at the same rate as their able-bodied counterparts. So there's so many, and of course, let's not forget COVID, where the number one determination of whether or not you contracted COVID is, do you have an intellectual disability? People with intellectual disabilities were by far the largest cohort of people to have contracted and been affected by the COVID epidemic. So what are we going to do about this? And now thankfully, we have now a renewed focus at CMS to make sure that individuals with disabilities can access the healthcare system. But I don't have all the answers. You invited me to be the guest speaker up here, but I don't have all the answers. But I do know that there is also that there's a number of barriers that are perpetuated in part by many providers, hospitals, and other clinicians who have outdated views about disability and stereotypes and just bias about people with disabilities who are accessing their care. And there's been a medical model that people with disabilities need to be cared for, but a lot of the issues are that people with disabilities, when they present themselves to the healthcare systems, are unrelated to their actual disability, right? A lot of people say, well, of course people with disabilities as a population have worse healthcare because they have disabilities. But when you look at the types of conditions that people are presenting with, there is no reason why somebody with an intellectual disability should have a higher rate of cervical cancer because of their intellectual, but that doesn't make sense. It's because clinicians, by and large, are even though we had Dr. Iazzoni from Harvard has focused on clinicians, asking them about people with disabilities. Most providers have no idea what their legal obligations are under the Americans with Disabilities Act or Section 504. They don't know that you need to provide a sign language interpreter to somebody who comes into your office who is deaf or hard of hearing, for example. So, and that it's not okay to ask the sister or the husband or the child to sign for them on their behalf. There are these types of accessibility issues. And just the bias of, there's studies that have shown, for example, a recent study that showed only less than 20% of emergency room doctors say that they would be happy living with paralysis. Would be happy living with paralysis. 20% of emergency room doctors said that they would be happy living. Meanwhile, you poll individuals with paralysis, and over 90% of individuals with paralysis report having a high quality of life. So, we've seen how in the crisis standards of care during the COVID, when we all of a sudden had the real possibility where we were going to have to allocate these scarce ventilators, and other hospitals, as you remember, we were watching the news every night. They were overwhelmed by these hospitals and healthcare workers having to prioritize and triage patients as they came in. And there were 6 states, Alabama, Utah, Washington State, I can't remember all of the states, including several regional healthcare authorities that actively adopted policies that put people with disabilities at the bottom of the priority list for accessing scarce treatment and access to ventilators. So while that's kind of a crisis standard of care, there's so many issues that I think confront people with disabilities and people with chronic illnesses in the healthcare setting. And I think that we should be working together to help Medicare develop policies so that these types of situations do not continue to happen in the future, including, am I talking too long already? If my wife were here, she'd get really mad at me right now.
But she's not here, and we're very
but there's
engaged.
just one more point I'm gonna make, and then I'll stop and listen to some questions.
It was very exciting.
What? Oh, okay. Is that there's very little, if no training whatsoever at the medical school level, at continuing medical education, either with physicians or other clinicians, nurses, others, about clinical competency when faced with somebody with a disability. It doesn't exist. Now, interestingly, under the oral care, that's another health disparity, by the way. If you have a disability, your chances of you having poor oral care, okay, which is not related to your disability. It's because that's just one of the poorer population health outcomes that exist. But fortunately, it's called CODA, the Council on Dental Accreditation or something like that, now requires dental schools, and it was pioneered by NYU School of Dentistry, so that every new dentist that's being trained at NYU, and now it's spreading around the country, has a component, a classroom component dedicated to providing oral care services to individuals with disabilities. Okay, so that we know this can be done. The federal government pays for so much of healthcare that we think that there's a role for the federal government in requiring, quite honestly, people who are trained in the medical profession to be aware of some of these clinical competencies when it comes to treating people with disabilities. Okay, that's it. But thank you. I just want to say it's also great to see you, Judy. And as you know, that because the Center for Medicare Advocacy has, I mean, many of you flew down from, I thought I was going to see you on my plane this morning, but you know, you all got here because of course you have a huge conference to put on. But we all are so fortunate that you are, your other home port, so to speak, is Connecticut. And the people of Connecticut really benefit tremendously by your presence there and your thought leadership and your advocacy. So thank you so much.
Thank you, Ted. I really appreciate your enthusiasm, love, and commitment exudes, right?
Thank you.
Let me say a few questions that I'll ask. When I said I wouldn't surprise you, what I really wanted you to know, I think you were very worried that you were going to have to hold forth about Medicare. And not everybody, like, really is fascinated by Medicare. I mean, you know, some of us are, some of us have other interests, you know. But I think that we've hit on something that is really important as a new focus. And I know that Judy Heumann recently passed away, a pioneer in disability rights and a friend, and I offer condolences. I think that we've here just now again unearthed a silence of people with disabilities when we know that Medicare is so often referred to as for seniors, when we forget that the program needs to respond to the almost 15%, Tricia, who qualify due to disability, and because, please God, people with disabilities age, and people who age become people with disabilities. So how can we change the language, alert the cadre of people who live with disabilities and who rely on Medicare or who may rely on Medicare in the future to insist that this program meets their needs of ongoing chronic conditions, conditions from which they may not improve, which is why we met in the first place over GMO, right?
That's correct.
And I wonder if you have any thoughts about how we might marshal that energy, including, as you saw, Adi Barkan has realized he must come up about Medicare Advantage, because if Medicare for all is going to be the future and Medicare Advantage is what universal health care is going to be, it's going to be really crummy for people with disabilities.
Well, it is, and I think the focus on GMO, although it looked at services in many different settings, it also focused on the home setting and home aids, et cetera. And I think that is the place that people, first of all, people with disabilities, they want to live as long as they can in the community. It also happens to be the cheapest place to provide. I mean, now they have healthcare companies that, guess what they're doing? The doctor comes to your house, right. Okay? Well, I'm old enough to remember when, like, the doctor would, like, come over to my house when I was, like, a little kid. And it's like, now? Oh, that's the brilliant invention that the doctor comes over to your house. But, I don't know, you just stick or you live long enough, and some of these ideas may circle their way back, right? But the point is that the home, in care in the home for as long, and of course the Olmstead decision held, the Supreme Court decision in Olmstead held that people have the right to receive those services in the most integrated setting possible. So I think that there's so much, but as you pointed out, the 90% drop in Medicare home care services over the last 20 years,
Yeah.
right?
That's
an astounding. Did you guys pick that up, that statistic? At a time where we need to be increasing home care, right? We've seen a 90%, and under Medicare. Medicaid is picking up a little of the slack, but guess what? It's not people who just need that benefit. And, you know, we all pay for it as a society one way or another. You either take care of people where they want in the cheaper setting, or, you know, we're going to pay for it, in my opinion, you know, down the road. So I think that is one of the, because there's a network in the United States of Centers for Independent Living. So these are called CILs, and there's about 400 Centers for Independent Living across the United States, based on the Berkeley, California model that Judy Heumann, the woman who we just mentioned a moment ago, was one of the pioneers in creating the Center for Independent Living. That was, the idea is to encourage and provide direct services to people to allow them to live as independently as they possibly could in their communities. And so I think that you know, there's a lot that we can do to work together to ensure that you know, even the Jimmo case now, people are not availing. They are afraid of getting audited.
Right.
People provide a service. They're afraid they're going to get audited, and then that's going to you know, put them at risk for all the other billings in their you know, in their organization. So that kind of thing has to stop.
Yes, absolutely. Do you see in and I don't know how much you are aware of this, but you talked a little bit in your remarks in our discussions about diagnostic overshadowing.
Yes.
And I wasn't aware of what that term meant. I wonder if you could talk a little bit about it. I have a sense of what it might mean. And also how it and if capitated payment systems in private insurance and Medicare Advantage create problems for people with disabilities.
Well, those are two different questions. One, the overshadowing issue speaks to a lot of the bias that exists in the healthcare system, viewing the patient in the medical model. When somebody with a disability comes into the doctor's office, they're automatically a physician, and this is not just me saying, these are studies that have borne this out, that the clinician's mind is already running wild with what the problem is with that person, without actually like taking the time to figure out what is the condition that's, you know, that the person is coming to see me about, right? So, or the prescription, whether it's a literally prescription or a diagnosis, is misfounded because of the bias that exists on behalf of the provider. So that's where the overshadowing comes in, where somebody is presenting into their office, and then not, whether it's somebody with a chronic kidney problem. By the way, people with disabilities do not get transplants at the same rate as their able-bodied counterparts, because after all, why give somebody with a disability a kidney? I mean, look, their quality of their life is so bad that, in fact, you know, this would be bad. This kidney needs to go to somebody else with a higher quality of life. So there's a lot of misperception that's out there that we know and has been measured and benchmarked by many peer-reviewed studies. Now, the principles of capitation, we all know the principles of capitation. You're paid a lump sum, and if somebody can deliver the care more efficiently, they get a bonus. They get to pocket the money. In some ways, you could kind of understand, because guess what? We're moving towards a value-based system. Every time I don't know, I subscribe to all these health newsletters. I mean, I'm sure we all read the same thing. Comes into our mailbox every morning, and you would think there's no other idea out there, right, than value-based care. Now, I do think there may be some positive things about value-based care, because we don't want wasteful care, obviously, but it does mean that people are incentivized to trim on needed care, right? Do you get what and because people with disabilities may have higher healthcare needs, I mean, we've seen this before, when recruiting people. If you're a Medicare Advantage plan, do you really want to recruit a lot of individuals with chronic illnesses into your health plan? Probably not. I mean, there are these risk adjustment scores that are trying to adjust for people, for those factors, right? But I can tell you that if you're an insurance company, you just don't want a lot of high utilizers in your plan, right? And so I do think that we need to be careful that people are not unfairly, and I don't know if there's any studies that have looked at, is traditional Medicare, do they have actually a higher percentage of individuals with chronic illness than Medicare Advantage? I don't know if anyone in the room has the answer to that question, but I do know that a lot of these barriers that you just talked about, the cancer treatment, the fail first on pharmaceuticals, and the other things tend to impact individuals with disabilities more
disproportionately,
more than others. Yeah.
Thank you so much. I think we have
I don't
time
know,
for one or two questions. Are there any questions?
Not that guy. Peter Thomas and I have been friends for 40 years? 1980. Wait, what year is it now? 2023? Oh my God.
We skied together.
So
Peter
Thomas and I used to compete on the U.S. disabled ski team together. Peter Thomas was much faster, won a lot more medals than I did.
That's very
and
kind
now it's been one of the pleasures of my life to be able to continue to work with Peter Thomas, because you've devoted your life to advancing the rights of people with disabilities too. So here we are at a conference together after all those years. It's pretty incredible, isn't it? Yeah.
Very, very kind of you, Ted. Thank you. I actually was in a car accident in 1974, so you beat me by a year. And we share the prosthetic use of prosthetic limbs, which is great. So I must tell you,
terrific.
It's a very exclusive club, by the way.
It's great.
So I was wondering, because we have done some work together on PACE programs for all inclusive care for the elderly. And I was wondering if you could talk a little bit about that model and what you feel about it, and not just for people over 65, kind of frail elderly, I think they refer to typically. I'm not sure if that term is going out of style or not, but what about a PACE model for a disability population as well? I'm just wondering what your thoughts about that.
Well, I think that the one thing that you can say about a model like that is the care coordination, right? Which it does, and which the Medicare Advantage plans do tout as one of their capabilities, which I think we need to pay people to coordinate care, and we probably need to do a better job of that under the Medicare program. In disclosure, I'm on the board of a PACE program. So I am, I'm a believer in that, even though it's a tiny, tiny fraction of the overall, Medicare, Medicaid spend. I think the model is a good model because it looks at not just direct care services, it looks at things like food and laundry. It turns out that if you feed people and help them with their laundry and help them with their bathing and things like that, guess what? They don't go to the emergency room as much. So this whole thing is food is a medicine, which is actually like now it makes sense to me, right? I'm a big believer in the PACE model because I think it's comprehensive, and I think it can be expanded dramatically. There's so many dual elements. It's for individuals who are duly eligible. And of course the socialization. There's a tremendous loneliness factor for a lot of seniors out there, and people. The alternative is living in a skilled nursing facility, which some people need. But if you can keep somebody out of a skilled nursing facility for as long as possible, which the PACE program does, I think that that's a true value.
Thank you. Well, Ted,
is it over yet? It's
over.
already over?
Yeah.
This is incredible. I got to come back next year.
All right. You heard it here.
Thank you so much. And can I just say one more word? Before you're presenting me? No, but today and through CMA, I've met so many people who worked with my father over the years while he was in the U.S. Senate. And I just want to say thank you because, as you all know, healthcare for all was the dream and the cause of my father's life.
Absolutely.
And he did so much in his years in the Senate to advance healthcare coverage for many. He didn't get everything he wanted, but he was relentless and he would chip away at trying to expand the benefits for all Americans. So, and I know many people in this room were part of that whole mission too. So for that, I want to say thank you.
Thank you, Ted. And we want to say thank you to Ted. We do have a token of our appreciation in recognition of your important contributions to health care access and coverage for all. Your dad would be proud. Including individuals living with disabilities. Mr. Kennedy's life as a leader in the disability rights and independent living movement and his shepherding of numerous healthcare reforms while in the Connecticut State Senate have greatly contributed to policy improvements that encourage better, more equitable healthcare for all.
That is so nice of you. Thank you.
Thank you so much. What a lovely day. What a lovely day.
Thank you all for inviting me. I look forward to working with all of you in the future.
And we'll see you back in Connecticut.
We'll see you back. Thank you.
Thank you.
I will. Thank you. Thank you.
I want to thank our program sponsors, American Occupational Therapy Association, John Kirkendall, Mansfield Family Practice, the Medicare Rights Center, the Michael J. Fox Foundation, and the Rothkopf Law Group for helping bring this component of the program. And now I would like to, where's Jeff? I think this would be a good, or Scott, a good time to show the, we have a lovely remarks from Senator Sherrod Brown, who received the Rockefeller Lecture. You probably have the date there in your program, but anyway, a number of years ago. And Senator Sherrod Brown is another gem. And we all need to support those folks in public policy who are trying to advance access to health care and justice in this society and see everyone. He sees people with disabilities, he sees wrong, and he tries to right it. So Senator Brown.
I'm Sherrod Brown. It's an honor to serve Ohio in the United States Senate. Thanks to the Center for Medicare Advocacy for all the work that you do, serving as a resource and an advocate for Medicare beneficiaries and helping to make health care more accessible to everyone. Thank you to my good friend, Senator Rockefeller, for your continued leadership and dedication to making Medicare a stronger, better program for older Americans. And on a personal note, Jay Rockefeller really, in many ways, mentored me in my time in the Senate. I'm so thankful for his guidance through those years. We know insurance companies, big pharma, corporate executives make sure they always have a seat at the table when we talk about health care. But the millions of Americans on Medicare whose health and livelihoods are at stake have been pushed out of this conversation for far too long. Your work gives them a voice. We've made progress on improving their lives and cutting costs, thanks in large part to your help and advocacy. Last year, we passed the Inflation Reduction Act to finally take on the drug companies to lower drug prices, particularly for Americans on Medicare. Thanks to that law, seniors on Medicare will never have to pay more than $35 a month for insulin. Their out-of-pocket prescription drug costs will be capped at $2,000 a year starting in 2025. And for the first time ever, Medicare finally will be able to negotiate directly drug prices. We've been fighting for this for years. The Inflation Reduction Act makes a huge difference in the lives, in the medical bills of so many people. Big Pharma rarely loses, but they did this time. It's a victory that shows how vital your work is, your work in advocacy. We've made progress on addressing prior authorization requirements that delay or in many cases restrict access to care for those who rely on Medicare Advantage. We fought to keep money in people's pockets and to ensure access to the highest quality care regardless of whether somebody relies on traditional Medicare or Medicare Advantage. And we'll keep fighting together to fix the observation status loophole. Dr. King in the letter from the Birmingham jail taught us that progress never rolls in on wheels of inevitability. Progress never rolls in on wheels of inevitability. It rolls in because of advocates like you who just don't give up, who dedicate your lives to progress. Your advocacy is so important in all these efforts. I look forward to continuing our work together. Thank you so much.
I always say half of the battle is to just tell folks you're not giving up, right? You're not going away, particularly when you're dealing with insurance companies. We do have a time for a stretch, right now, and then we will be having our wonderful Alfred J. Chiplin Social Justice Award, and I will then want to mention the alum here who and current staff who knew and loved Chip. So please just take a stretch and be back with us and Jen Poo and her wonderful panel following that in just 5 minutes, 4 o'clock. Thank you. while we're gathering, let me say another set of thank yous. There are 3 members of our board of directors here. Our chair, who you met earlier, is still here somewhere, Judy Fader. We're also joined by Charlie Sabatino. You want to say hello, Charlie? Thank you. And I know Sean Kavanaugh is here as well, but he may be on the phone as well. So I was trying to wait to say thank you to them before when they'd be in the room, but time is wasting. And in addition to Ted Kennedy, I want to thank Kathy Hurwitz, who's also on our advisory board. And there's something about just knowing that people of the caliber in every way of Kathy are behind you and with you that really makes a difference. And same to Ted's, our wonderful board of directors, Charlie, Sean Kavanaugh, who are here today, and those who can't make it. So this is a moment that is both very dear, very, very dear to my heart, and very significant to the Center for Medicare Advocacy. When we award the Alfred J. Chiplin Jr. Social Justice and Advocacy Award. And I'm hoping very much that while I'm speaking right now, that I'm also speaking to Chip's family, Jewel and Lucille and Larry and Tasha and her Larry and Violet and Lily, who couldn't get to DC today, but they're part of the Center for Medicare Advocacy family. Alfred J. Chiplin, Chip, who many of you knew, but not all of you, and let another nod to Matthew Huppert here, who helped make some of the last days of Chip's life more full of work and able to, let me say that again. He was able to be with us at work, which was extremely important to him, in part because of you, Matthew, and we always remember that, and you. Alfred J. Chiplin Jr., Chip, was a beloved and admired leader in the elder law, disability, and healthcare rights communities. He was also the longtime managing attorney of the Center's Washington, D.C. office. To honor Chip's advocacy and commitment to civility and justice for all, the Center for Medicare Advocacy established an award in his honor, now in his memory. The Alfred J. Chiplin Social Justice and Advocacy Award is given annually to an individual who works to advance civility in society and social justice for all, as Chip did over his 40-year career as an attorney, a brilliant human being, and an ordained minister, and a man of truly, in every way, a great voice. I'm honored today to give that award and to have her accept the award to I-Jen Poo. I-Jen is a next-generation labor leader, award-winning organizer, author, and leading voice in the women's movement. And just out from being honored at the White House yesterday. She is the president of the National Domestic Workers Alliance, executive director of Caring Across Generations, senior advisor to Care in Action, co-founder of the Supermajority, and trustee of the Ford Foundation. I-Jen is a nationally recognized expert on caregiving, the future of work, and organizing. She's the author of the celebrated book, The Age of Dignity, Preparing for the Elder Boom in a Changing America. I-Jen is an inspiration to women and human beings everywhere. And I'm really honored, as is the Center for Medicare Advocacy, to award you the Alfred J. Chiplin Advocacy and Social Justice Award.
Oh, wow. Thank you so much for this incredible honor. Incredible, incredible honor. So many people have shared special stories with me about Alfred Chiplin. Am I allowed to call him Chip? Yes? Okay. He was clearly not only an incredibly effective leader and advocate, but also a very special human being. Who meant a lot to so many people in this room, but in our community of advocates, it's so clear. And that part of it all is very meaningful to me. And it's also just so meaningful to be here gathered 2 days after the President of the United States signed the most sweeping executive order on care in history. More than 50 actions directing every agency in the federal government to better support family caregivers, care workers, and families who need care. I hope that you realize the historic significance of this and the fact that this organization had a huge role to play in getting us here to this moment. The care economy has just never been recognized or supported. And this week, the highest office in the land not only recognized the care economy, but put bold action behind that recognition. And truly, this moment would not be possible without the Center for Medicare Advocacy and people like Alfred Chiplin and the many other organizations and leaders who fought for years and years, protected and strengthened and fought for the policies and programs that we have and the programs that we need to live and work with dignity, to age with dignity and agency. It's not particularly sexy work, but it's very, very meaningful work.
Yes.
And it's the work of building trust and relationships, seeding ideas, telling stories, and the stories that we all know but actually never hear in public talked about. So for all that unsexy, incredibly meaningful, powerful work that you have done over many, many years, I just want to say thank you to all of you in this room and to Judy for your leadership and to the Center for Medicare Advocacy. And I also want to say a special thank you to all of you because when we started Caring Across Generations over a decade ago, we were the new kids on the block. And a lot of people in the policy world kind of looked at us and were like, who are you and what are you doing? But this organization actually welcomed us with open arms and was very happy to see new kids on the block. And I think that's the right, here we are, we're still here working together and it's pretty great. And you not only welcomed us, but you actually taught us about the policy that we needed to understand and how it impacted the people that we care about. And we're so grateful for that. You helped us. And you made space for us. So I'm so grateful. And from what I've heard about Mr. Chiplin, it sounds like you had a model in this organization, someone who embodied the kindness and spirit of collaboration that has become your MO, and we're all better for it. And a little bit about me is that I grew up in an intergenerational household with my grandparents on both sides. They helped to raise me from the time I was 6 months old. My grandmother taught me my first language, Mandarin Chinese, and my grandfather and I used to watch Wheel of Fortune together every night. That was his favorite show. They both actually taught me my values, and they kind of gave me a vision for the future, set my North Star, and I can't imagine who I would be without their love, their guidance, and their care. And so I was really attuned to their needs as they aged, and my grandfather lived a very long life, but eventually lost his vision. And that catalyzed a host of other health issues, and my father just couldn't find the right care for him at home. So we had to place him in a nursing home against his wishes. And the facility was really, really quite a nightmare, actually. The lights didn't work. He couldn't eat the food. He shared a room with 6 people, half of whom were miserable, the other half unmoving. He passed away after just 3 months in that facility, fearful and alone. And we live with that, with regret from that experience, my whole family. My grandmother, on the other hand, passed away 3 years ago at 94 at home, where she lived with my mother and the support of many home care workers over the last decade. And because of that support, she was able to go to church twice a week for most of the last decade of her life. She was able to sing in the church choir, play mahjong with her friends, get her hair permed every Saturday at noon or washed. You don't perm every Saturday, but you know, maintenance, very important maintenance. And having the round-the-clock care that she had at home meant that even as she became more frail and her dementia worsened, she was still able to see my little niece regularly and be a part of her childhood, a really important part of her childhood. She was able to live life on her own terms with a totally different quality of life from my grandfather for a very, very long time. And a few things that we learned from this experience is that caregiving is an intergenerational experience. It's an experience that everyone in the family shares. And our ability to care for our children or our elders is something that really affects all of us. And that life is hard enough, dealing with your loved ones becoming more frail or watching a loved one with dementia disappear before your eyes. It's just hard enough emotionally without the financial and practical stressors of affording and managing care in our current environment. Caregiving can be some of the most meaningful experiences of our lives, but it's too often overshadowed by hardship and struggle because we don't have the systems and the infrastructure and the support in place to support it. My family didn't have a plan for the caregiving that my grandparents needed, and really didn't have anything in place to help us navigate the realities that we faced. And I realized, as I was kind of experiencing all of that, that the country doesn't really have a plan either. And the pandemic, I think, revealed just how dangerous that is. At the heart of our public health crisis was a care crisis. And we're still deep in it because as a nation, we have not yet built the kind of care infrastructure that we and our families need to stay resilient. Yet. And that is what this moment is all about. We made a huge leap forward this week, and this movement for care is growing in strength and momentum and breadth and depth, and we're just getting started. We passed a bill in the House of Representatives called the Build Back Better Act with hundreds of billions of dollars for care. And while we came 2 U.S. senators short of getting it across the finish line, we have moved the care economy and investments in the care infrastructure into the heart of the public policy conversation in this country. There's no going back now. And we've got this historic executive order to celebrate, and we're going to continue working until every single person in this country has the care that they need at every stage of life to live, work, and age with dignity. And we're going to make sure that every job in the care economy is a good job with living wages and benefits. And we're just really excited. I don't know if you're as excited as we are, but we're just really excited about how far we've come and the potential for real, meaningful change. And we're so honored to do this work with all of you. Thank you so much.
Yes, we're so excited, and we are with you and of you, and hope that there will be a national system to support caregiving and to recognize that all jobs are good jobs if they pay well, if they train well, if they retain people well, and can create a community of people who do good work. So in honor of all your work, we award the Alfred J. Chiplin Jr. 2023 award to you, Ai-jen Poo. It's awarded to an individual who works to advance civility in society and social justice for all. In recognition of your decades of dedication, expertise, and compassion and success as a leader and advocate for the rights of domestic workers, elder and family care and caregivers, gender equality through your guidance, writing, and organizing.
Wow.
It's
beautiful. It's beautiful.
Thank you so much.
Yay. Better than an Oscar.
Yeah. Next year, the Oscar. And we hope you also enjoy this seminal book by Representative Lewis, and I have one for each of you as well, because we must keep marching.
Yes.
We must keep marching.
Yes. Beautiful.
Thank you for
Thank you so
participating.
much.
Thank you. Thank you, Ms. Chin.
Thank you.
As some of you know what I mean, I'm a bit verklempt.
Me too.
And just a moment, Ai-jen, my work is really powered by my relationship with my grandfather, who I saw every day for the first 11 years of my life. And that's why I push for social justice for people who used to be a lot older than I. Ai-jen has also graciously agreed to moderate a panel about caregiving and caregivers. And she's joined by two remarkable folks. One is my dear friend who I've just met, but it feels like there's been on Zoom, at least, and now. And Sophia Colley is a CNA at a nursing home in Titusville, Florida. She was born in Jamaica and started working in healthcare soon after arriving in the United States in 1989. She is an active MPO delegate and spokesperson for 1199 SEIU in Florida. For 10 years, we have been graced and partnered at these events with SEIU. She has testified before the Florida Legislature Health Care Committee, served as an expert panelist at the Silver Solutions Coalition Summit, and has advocated for health care and union worker needs at numerous other roundtables, conventions, and events. She had an adult daughter die in a 2013 bout with sickle cell anemia. And she attributes to the lack of affordable health care. And she does have another daughter who is a paramedic. We send them all our love. Nicole Jorwick also joins us. She is the Chief of Advocacy and Campaigns at Caring Across Generation. Of course, we welcomed Caring Across Generations. Before joining Caring Across, Nicole was Senior Director of Public Policy and Senior Executive Officer of the State Advocacy at the ARC of the United States. Before coming to DC to work on federal advocacy and organizing, Nicole served as Senior Policy Advisor and Manager of the Employment First Initiative in Illinois, and prior to that appointment was CEO and President of the Institute on Public Policy for People with Disabilities. Thank you so much, and thank you, Ai-jen, for leading this crew.
Yes. All right. This is going to be great. We are going to talk about caring for caregivers. which is my favorite topic. And I'm so excited to talk to these two brilliant women leaders about this topic because they have a lot of firsthand experience both in their own lives and also as organizers and advocates. And I want to start with you, Sophia.
Okay.
Give us a sense of your day-to-day.
Okay. My day-to-day work in the nursing home, working in the nursing home for me is a very rewarding experience. First, you have to love the work you're doing. You have to love the people. You have to be compassionate. They have to trust you enough to be able to care for them without being harmed or injured. And so whenever I get to work in the morning, I never want to get to work in the morning and wonder, do we have enough staff today to care for the residents? Sometimes, since COVID, it gets worse. We don't have enough staff to care for the residents. Sometimes it's 1 to 10, 1 to 20, and it takes away the quality care that you want to give to your resident, because one day it could be me, and I really want to be cared for in that kind of manner. So a resident might have to wait until their food is cold before we can get to them. So this lack of staffing is very, very bad in order for us to give the quality care that's needed to our residents.
Yes, I've heard, and I also experienced that with my grandfather, that the direct care workers in the facility, they had 25 people that they were responsible for.
Some today say they have is 70 to 2.
Oh.
I think it's in Pennsylvania, it's 70 to 2. Yes.
Talk to us about the challenges. So the staffing is one. What else are what is the staff facing?
The staff are facing right now, as I say, short staffing, lack of resources to be able to provide quality care. Sometimes you don't have soap to give the resident a proper bath.
Wow.
The equipment in order for them to get their ambulatory care, to go to therapy. Sometimes they don't have clothes. We, the staff, sometimes provide clothing for them. Some of them has no family. Majority of the residents don't have any family. So we are their family. They depend on us to care for them. So it's very challenging when you don't have the resource that you need to take care of the resident. We buy our own soap, and we have to be careful because some of them are allergic to, it's allergies, so we have to be careful of what we bring in to care for them. So it's right now it's challenging, and so we are looking for help, for funding in order to help with this ratio of 1 to 20, 1 to 40 to care for the elderly.
Absolutely.
And it's not just the older people now. We have the young that are in the nursing home. We have the disabled. We have the homeless. So it's not just older people anymore. It's a variety of different people.
Yes. Wow. And I know you talked about the need for more funding, and we're all advocating for that together. That's absolutely essential. And while the executive order that the president signed doesn't have new funding, it was very significant. How did it feel to bear witness to that?
It took me 58 years to get to the White House and to witness that. It tells me that our advocating, our lobbying, our social media posts, our any kind of media post, that he's listening. Somebody's listening. So to witness the signing of that was very exciting for me. And it gives me hope to say, well, we'll continue with this fight. There's always an end goal to something. So with this fight, there will be an end goal. So that's why we're going to continue the fight to reach where we want it, so we can be able to give the quality of care to the elderly and those who need our care.
Beautiful. I want to bring you in, Nicole. You've spent your life in the disability justice world and now at Caring Across Generations, building this care movement with me and so many others. How did you get on this path?
Sure. I have a brother, Chris, who is 33 and has autism. But actually, before Chris was even born, I was in the first included classroom in my school district. So I've been really lucky that disability and integration has been part of the fabric of my life from the very beginning. And I was a direct care worker all through college and law school. And now I'm also, in addition to supporting my brother, I also do a lot of support for my grandparents. My grandma has Parkinson's and my grandpa's been having some issues lately. I figured out in the last year I've spent 1 month down in Florida with them providing direct care because of the lack of the system that we have. So even as it's real demoralizing to be a quote unquote national expert and still not be able to find the answers for your own family members. So that's still what drives me to keep doing the work that we're all doing together.
That's right.
It's so
That's
true. I mean, it's like even those of us who spend all day thinking about these programs struggle to navigate them.
Yep.
Imagine for the average, right? We don't have to imagine. And talk to us about the relationship between your role as a family caregiver and the role of our direct care workers.
Yeah, it's so incredibly important. I mean, talk about interdependent. We talk about intergenerational. We also talk about interdependent. For so long, maybe workers were fighting for one thing, the disability community was fighting for one thing, and the aging community was fighting for another thing. And as with 2017, with some of the attacks that came together with COVID, really is when it coalesced to really show that we all have to be in lockstep if we're going to get the big investments. We're not talking about something that obviously just appeared during COVID. We're all systems that were broken well before then, and we have to work together, because as a family member, I want the workers who are supporting my family members to be making a family sustaining wage so that they feel good about coming to work every day, to have paid leave and paid sick so that they don't have to come to work, and that they can take care of their own families. Right. And it's incredibly important that we're working together, or else it's going to continue to be where family caregivers, like where I'm filling in the gaps for the system that doesn't exist. And then the other leg of that is an underpaid and undervalued workforce. That's not going to work. So we have to work together to build a system that we all need and that everyone deserves.
Certainly.
And I think that I just heard you talk about the relationship between the quality of jobs and the quality of care that you provide. And every care worker that I've ever met really does see this work as more than just a job. Right? This is a calling, and it is so much about what you do for the people who are relying on your care. Exactly. And it's, in some ways, it doesn't make sense that these interests have been siloed or pitted against each other, because there's no way to actually realize access to services without a strong workforce, right? We can barely maintain the workforce that we have because the wages are so low, exactly. Right? And so what do you think needs to be done about that?
We need to continue to advocate, because we cannot continue like this with no staff to take care of the resident. The ratio is bad. Mm-hmm. And in order for us to give quality care to the residents, we have to keep fighting so that something can be done in order for us to have the adequate staff. Mm-hmm. Because it's, as I said, it's getting from bad to worse. And, and so we can't continue like that.
Well, I know, Sophia, one of the big ways that workers have been able to realize change in staffing ratios and wages has been through union. Right, through being a part of a union. Talk to us about the difference that being a part of the union has made for you.
Wow, being a part of the union, oh my God, it gives me the ability to
You see how she just lit up?
It gives me the ability to advocate, especially, when I was living in Jamaica, short story, growing up, my brother shot a bird with a catapult. I don't know if anybody know what that is. And I run towards the bird, and I found the bird fly, and I took the bird inside, and I sewed the bird up, trying to get the bird to fly away. But it ended up dying. We had a little funeral for the bird. And Years later, I did not know my grandmother remembered that before she passed. And she said to me, Sharon, I want to tell you something before you get on the plane. When you go to America, take care of the old people. But I never know how rewarding and that she still have that instilled in her head. And she said that to me. And then when I came to America, I tried everything else. I went to nursing school, surgical tech, medical assistant, but bedside care. The first time I went to work in a nursing home, I'm 18 years where I am now. When I went to work in a nursing home, it was just the pleasure of me just making somebody feel good. You know, it just feels to when I get you up and bathe you and make you look nice and you sit there, it just makes me feel, oh, my work is done. Thank you, Sophia, sometimes. Oh, Sophia, come here. And, you know, and I don't make a lot of money, but I will tell you, my car is at the airport right now with clothes that I bought for one of my residents because they don't have anybody. Some of them don't. And even when they, in the nursing home, they get rehab, and they used to be shorter rehab. Now it's longer rehab because we don't have the staff. And now when they go home, they end up coming back to us. They end up coming back to us because they can't afford to be home by themselves. So they end up coming back. And that's the reason why it hurts me not to have the staff that we used to have to provide the quality care. Sometimes they just want to hear a song from me because I like to sing to them. They just like to. We have doctors in the nursing home. We have lawyers. We have teachers. We have nurses. We have people that I advocate to make sure when they're in their room, it's something on the board if they can't talk to say what were they their profession, because they deserve the dignity and the respect, not because you're laying in this bed.
That's right.
And my grandmother instilled that in my head. It's not easy every day, but if you make it, if you go through that door with the love in your heart and know that this is someone's family, and one day, if it's me, I want to be cared for just like that. And that's what, you know, that's the compassion, the love. They have to be able to trust you, you know, to take care of them. And so that's what I want to see. I want the staff to come back so we can do what we like to do for the resident in a timely, respectful manner. You know, sometimes I just have a question to ask you, and it's hurt me when I have to say, I'll be right back.
Right.
But 15 minutes later, I'm not back, and all she had was, or he or she might have, is one question. Might be saying, can I get a snack? I don't have the time to go back, and I don't remember because I have to, and those things really hurt my heart. I cannot, it just hurts me. You know, it hurt. My dad had dementia, and I end up have to take care of my dad, and I end up have to put him in a nursing home. You know, because right after my daughter died, and there was my dad. And so, you know, it gives me the pleasure and I thank God for the gift that he instilled in me to be a caregiver. And I will never change it for the world. It's not easy, but I will not change that.
Sometimes when I watch Beyonce perform, I'm like, oh, she was born to do this. And listening to Sophia, I'm like, oh, she was born. You are the Beyonce of direct care. Nicole, there are policy solutions. I mean, obviously, we need to make sure that Sophia is freed to provide the care that she was born to provide, right? Without these undue pressures of terrible staffing ratios and low pay and all these things, not having the resources. What are the actual policy solutions to get us to a place where family caregivers are supported and care workers are able to provide the quality of care that they want to provide?
Yeah, there are policy solutions, and in my almost decade in DC, I've seen how we've been able to move towards problems that kind of work on the fringes but are incredibly important. I see my friend Tyree here, who I know was a beneficiary of the Money Follows the Person program to move folks who want to out of nursing homes into the community. That used to be the big thing, right? Let's get permanent MFP, which was really and is incredibly important. And that was like $6 billion for me. Like, I don't know, maybe it'll take 5 years. Well, the good news is that the pandemic and what it exposed has allowed us to move from talking to from about millions of dollars to talking about billions of dollars. Mm-hmm. And that's what we need in order to fix the decades of lack of investments. Right. And there are bills out there. So there are a couple that I want to mention. There, obviously, we need to continue to shore up the Medicare program, and obviously CMA is doing amazing work, Judy and David, around the home care benefit and Medicare. But with Medicaid is a program that has problems. It obviously has very strict financial eligibility requirements, but it is the main funder for long-term supports and services. Absolutely. And for the workforce. And so there's the Better Care, Better Jobs Act that pulled the parts that did pass the House and through Build Back Better that would add 10% federal matching assistance percentage over 10 years to raise wages for workers and also to expand access to services. And then there's kind of what we consider a North Star bill, the HCBS Access Act, or Home and Community-Based Service Access Act, that would make home and community-based services a mandatory program under Medicaid. But we know we can't do, and that would eliminate the waiting list, but we know we can't do that without funding the workforce. And so it also includes funding to raise wages for workers, because you can't pull the 700,000 people, and there's more than that, on waiting lists into the system because of the current workforce issues. So that bill would put 100% of federal dollars. It's obviously meant to be scalable, but 100%, of course, Judy laughs, 100% of federal dollars for 10 years to build that infrastructure that we need to create. And then also there's really important conversations going on of programs that are outside of the entitlement programs. Obviously, the Class Act that was part of the ACA and later repealed, some of the folks behind that are thinking about something outside of the program so that there can at least be a small benefit for folks that aren't going to be eligible for Medicaid, but still have those long-term care needs, including obviously also a lot of direct care workers. We need to make sure that as we're building a system, that everybody's needs are accounted for. And so you have the Medicaid pieces, you have shoring up of Medicare, and then you have something outside, or maybe that is pulling it into Medicare, as Representative Pallone, based off of something that Judy Fader worked on, would have created a Part E for Medicare. So there's a lot of good things out there, and we're only going to get there the more care folks see themselves in this issue, which is obviously something we focus on at Caring Across Generations, because so many people don't, they might be providing care. I had this with we were working with one of our communications consultants who was like, I'm not a caregiver, I'm just a care scheduler. I just make sure my mom's where she needs. And I saw it when she recognized, oh, that's me, right? And that's what we need to be doing. And so many of us who are in it as family caregivers or as care workers get stuck in the everyday because it feels like a crisis every day, that we can't turn to advocating, but we have to see ourselves in the issue. I remember having a harried phone call with Ijen, and I was like, it's so frustrating because we all have this in common. Well, now we have our Care in Common initiative, because it is something that everybody needs to see themselves in. Because if we're all lucky, it's something that we're all going to need.
Mm-hmm. One of the things that we've seen in our research is that caregivers don't actually believe that things can change, that it can be any different. And so just to close out this panel, I'd love to hear from both of you some closing words about why caregivers should actually believe that change is possible.
Because it is possible. It is, when we think positive, change is possible. And we just have to believe it and keep working towards it. Keep fighting. Mm-hmm. Keep fighting. Believe in what we're doing. Follow up on it. Just don't start it and don't do anything about it. Let it stop right in the middle. It doesn't just stop in the middle.
Right.
You start it, you continue it, follow up on it until you get to that goal to say, yes, we did it. Mm. Because as they said, care can't wait.
That's right.
That is right. And what gives me hope is the fact that we've broken down a lot of the silos between aging and disability and labor, and that means that we can win. And it means, and also what gives me hope is I also was lucky to be there with the signing on Tuesday, and I sat in the Rose Garden and listened to the President of the United States describe, and I'm going to try not to get emotional, but to describe the exact situation that my family is in. the situation where you have two aging folks that aren't making the right decisions for themselves, but there's really no solution that's good. And that recognition, the more that if we're getting that recognition from 1600 Pennsylvania Avenue, that means that we can get the folks at the other end to get us the policies that we need.
That's right. That's right. And we have come so far. I mean, if you think about this has always been relegated to kind of a special interest issue, right? Either the women's agenda, the aging agenda, the disability agenda. It is now a core pillar of the president's economic agenda. And not only that, yes, we should definitely clap for that. And not only that, but it's very holistic in its approach. It's not just aging and disability care. It's not just paid family medical leave or just child care. It's all of it. And for the first time, it really foregrounds the needs of the workforce.
Yes.
The need to improve the quality of care jobs. I mean, that progress is really huge. And it's not just in symbols. It's not just 3 lines in a State of the Union. It's a 50 directive executive order this week. I mean, come on. Change is possible. So we're going to put hundreds of billions of dollars back on the table in a couple of years. And until then, we'll keep hope alive and keep doing the work. Thank you so much.
Thank you, sister.
All right.
Oh, what success. Oops. Thank you.
Thank you so much.
Thank you.
We'll make good trouble.
Yes. And let's make good trouble together.
You,
Thank you. Stay in touch. Thank you so much. Thank you for traveling. Yeah, back at you. Well, it's hard to wrap up with that kind of energy and heart. And I understand that crew only learned on Monday that they were going to be hosted at the White House. Everybody said to me, "Oh, they must have known that for weeks." I said, "I bet they did." Right, Nicole? No. Yeah. Come on up, Jeff.
Hello, everyone. Jeff Wiseman here, Director of Development for the Center for Medicare Advocacy. Give it up for Judy Stein, everyone. Before we end today, I want to say thank you all for being part of our community. We have a saying at the center, our strength is our community. And we appreciate you all tremendously. Thank you. I also want to give thanks to our leading sponsors before we wrap up today. Arnold Ventures, the Reeve Foundation, the John A. Hartford Foundation, Henry Schein Cares Foundation, and Wilson Sonsini Foundation. Thank you so much for your support. Also, before we go, our friends of the summit, ALS Association, the American Medical Rehabilitation Providers Association, the Gerontological Society of America, Justice and Aging, National Academy of Elder Law Attorneys, and National Council on Aging. Thank you all. And for those joining us in person today and for everyone watching online, I would like to invite you to support the Center for Medicare Advocacy. Today, we have a matching grant opportunity, so your donation will be matched dollar for all summit attendees. Thank you so much, everyone. Thank you.
I neglected one thank you, and I still have one more. Wilson Sonsini Law Firm has been so gracious as a pro bono partner to the Center for Medicare Advocacy. Our litigation work comes with a very, very high cost in terms of work and resources and brain power. And boy, do we have that in Wei and in Allie and in the Kathy and in Kata and in the folks who help us, Gilda Ford. but it doesn't, we can't do litigation that's going to take 12 years, or the other side, 6 months and be dismissed. And then we have to figure out now, what do we do, because you know we won't give up. Wilson Sonsini has graciously sponsored the Alfred J. Chiplin Award this year, which was just a perfect match. And I want to thank them for that and for their incredible steadfast assistance, along with Justice and Aging, in our litigation efforts. I also want you to know that this event, in addition to our friends and colleagues at Spark Street, thank you all for providing this professional presentation electronically and for our folks at home. Other than that, it's run by the Center for Medicare Advocacy. We don't have an event planner. It's what you see is what you got. I want to thank Scott Perkins, our operations director. This is the summit team. Jeff Wiseman, our development director. Matt Shepard, don't hug him, thanks, just say thanks, communications director. And David Lipschutz, our associate director and policy director. We have been meeting occasionally and then constantly. That's the summit team. Then we were joined by staff, you know, Stephanie Aston and Aisha Hamid are outside still. I don't know why they didn't come into this room. And just folks on our board and staff and alum, thank you all so much. And blessings to the Chiplin family if you're still watching. We are having a reception to celebrate 10 years of being together and being finally back together in person. We hope you'll join us for a little while. And join us again next year around this time. Thank you all so much. Thank you, speakers, Tricia, and everyone else. Thank you.